Thank you, and thank you very much for inviting me here. I think it's useful for all of us to share experiences and so that we don't lose all the learnings we have from this huge event, I would say. I mean, public health has probably not seen anything like it for at least 100 years. My training started as an MD. I specialized in clinical infectious diseases and also did my PhD in infectious diseases, actually in wound infections after thoracic surgery. So I've been all over the place. I also did a Master of Epidemiology at the London School of Hygiene and Tropical Medicine. So that's my training background. I worked as a clinician until the late 1990s with some periods in WHO in that period. But after that, worked in different agencies in Sweden, but also at EU level. To start with, mainly in control of communicable diseases, but since the last 20 years, a bit more, I would say, in the broad public health. So I worked in different agencies, the National Board of Health and Welfare, which in Sweden mainly deals with hospital services, in-service and stuff like that. But for the last 10, 15 years is what eventually became the Public Health Agency in Sweden. Before that, we had two different agencies, one for NCDs, basically, and living conditions, stuff like that, and one for communicable diseases. They were fused a little bit more than 10 years ago, and I was part of that fusion. And so since then, I've been working in the broad field. I've there been the director of different parts of the agencies, but in the last 10 years, mainly in the area of data collection, data management, data analytics, modeling, those kind of things, for the broad area of public health, not only communicable diseases. And that role was also, during my time, connected to what we call the state epidemiologist. We can discuss that role a bit more later because it's quite complicated, and it has had different ways, both in the organizations and how to use it during time. But that was the reason why I became the spokesperson for the Public Health Agency during the pandemic. The Public Health Agency is one of 250 agencies in Sweden or something like that. So the whole Swedish system very much builds on different agencies. Our government is comparatively small, very much focused on policy, not on technical matters. The technical matters are taken care of by the different agencies, which means that the agencies has a wide mandate. And my former director said we work with everything from Ebola to snuff. And any kind of question might come to us, and we will deal with it. We will develop the knowledge around it, and we will give advice to the government on how to deal with it, what kind of interventions and so on could be done. But we have on top of that also mandate to actually have legislations in place. When there is a law passed by government, the government will then delegate certain parts of it to, or the parliament will take the law. They will delegate certain parts of the new law to the government to handle, and the government in each turn can delegate certain parts of it to the agencies to actually decide on. So one example in the area of vaccines, we can then, decide on, the government will say which vaccines it will be, we will decide on when they will be given and who will give them. So there is quite a big legal mandate that comes down to the agencies, which also means that agencies have quite a big role in legal matters, and we have a big group of lawyers working for us. And that also transpired into the pandemic, which meant that we were a very central agency during the pandemic. And I sort of became the spokesperson of that because of my role as a state epidemiologist, but also very much because of my role as head of data management, data analytics, which was really a central part of the management of the pandemic in Sweden. So that's briefly what I've been doing for the last 25, 30 years.
Thank you. In a nutshell, thank you.
Let's start with the three levels. The national level, well, let's start at the bottom. The local level is taking care of social services, schools, elderly homes, those kind of things in general. And there is more than 250 of those, and they vary size from maybe 6,000 to 7,000 people up to 500,000. So it's quite a... and that level, as all three levels, have their own political constituency. They have a parliament, they have a kind of government, they levy their own taxes. So they are very independent in doing what in the legal system is possible for them to do. The next level is the regional level, who basically concentrate on running healthcare services, but also responsible for public health. They're also responsible for culture and roads and a few other things, but most of it goes to... and once again, they have their own parliament, own voting system, levy their own taxes and all of that. And then the national government, of course, can put laws and stuff like that into place, but has a very limited operational both capacity and role in running public health in different ways. In a crisis, the Swedish preparedness system and a crisis management system builds on one principle that's very strong, and that is whoever has responsibility for something in peacetime will also have it in a crisis, which means that we do not really change the structures at all during a crisis, but it keeps on running in the normal structures that we have in place normally. So there is no way of sort of taking over the decision-making or mandate for anybody in this, unless government and parliament gives a go-ahead. So during the pandemic, that also happened. I mean, the communities kept on running the schools and the elderly homes and so on. The regions kept on running the health services. And the national level mainly focused on seeing what legal things needed to be put in place, and also in coordination in different ways, and of course handling the international, all of these kind of things. And at the governmental, the national level, Swedish agencies has, as I was a little bit saying before, has a stronger role than agencies in most other countries. They are, by legal mandate, independent. The director is put in place by government, but done in an open process with the most qualified person getting the role, at least officially. So, and then all the people in the agencies are employed by the agency. And the agency gets its money yearly with certain instructions from the government, but quite open. So what the agency does within its mandate is very much up to the director and the agency itself. So there's quite a lot of independence in it, even if there is, of course, continually a very close communication with the political level. In the end, these bodies are, appointed by a legal act. So they have a very strong legal mandate in many ways. And that's also what happened during the pandemic. The mandates did not change, not at the national level either. The government sort of kept its role as a lawmaker and to take care of what things needed to be done at that level, and the agencies took care of their respective role that had in peacetime kept those. What was special this time is, and we don't really have a system where one of the agencies can become a lead agency. So all the agencies are basically at the same level. But in practice, since this was very much of a public health, it has consequences for everybody, but the core of it was public health. The public health agency became sort of the lead of it. And the government made that clear by issuing a directive that we should have daily press conferences together with the National Board of Health and Welfare, who took care of the hospital services, and with MSB, the continuous agency, who takes care of the civil response in the society, together with the regions and together with the communities. So that, and I think that sort of also implied how the government sort of saw the who was going to sort of help in leading this, even if the operational aspects, all of them were basically taken care of by the communities or the regions. So we kept on having these daily press briefings, those three agencies. There were also occasional press briefings from the government level, not that often, and mainly when the government sort of needed to go in and do some kind of legal change in the structure or something like that, or so other reasons for them to be. But otherwise, this was very much technical kind of things. We did 198 of them, so during the 2-3 years. So that's, yeah, it is a fairly complicated structure, which builds very much on grassroots contact. And with all the strengths and the weaknesses you have in that kind of system. So, and the public health agency has a very limited possibility to actually enforce what the regions should do or what the community should do. So it very much builds on networks and giving them good advice on what's reasonable to do. And we had twice weekly meetings with all our contacts out in the regions. Each region, by law, has a communicable disease officer.
And we'll come on to ask you in more detail about that. But if I could just ask you, you mentioned, I think, that with the funding come instructions. What sort of instructions?
They would mainly be that the government saw a problem and they wanted to have advice on, or technical, scientific background to what can we do about this. I mean, a recent example is all the screens we are looking at. They were asking us, okay, what do we know about the problems with screens? What could we possibly do, especially in children, when it comes to screen time and so on? And then we would put together a group, internally and externally, and deliver advice to the government. Okay, this is what we think is reasonable to do in that area. So it would be those kind of instructions.
Thank you. And is the funding connected or linked to a particular instruction, or is there funding there?
The big part of the funding is constant, and it's not connected to any specific instructions. But sometimes when the government sees that this is a very big thing they need to do and it's sort of outside of the normal scope, there will also be added funded for specific inquiries like that.
Thank you. Could I just ask you, and you've probably touched on it already, but just to explain the principle of decentralization?
Yeah, I mean, it means that, of course, there are laws in Sweden regulating how health services should be delivered to the population, for example. But the laws are quite open, very much oriented towards this is what you're supposed to achieve, and not what you're supposed to do. I mean, there is no law saying that you need to have so and so many hospitals and so many beds or anything like that. But it basically says that you're supposed to deliver healthcare to your population in an equitable manner, and it should be similar to what's delivered in the rest of the country. So that's how sort of the regions, and in a similar manner, the communities are regulated on what they should do in a very much oriented towards what are they supposed to achieve, not how to do it.
And in terms of the NBHW and the MSB, what are their roles?
The MSB's role has by many been considered vague, but because their role is mainly to assist the different parties, because they don't really have an operational role of itself. So their role is mainly to assist the different partners in the Swedish civil contingency system in improving their preparedness and improving their capacity to manage a crisis. And then they have a vaguer role in collecting information during a crisis and supplying that to the government. So what they did during the pandemic is that they asked the regions and the counties to deliver weekly updates on what is happening, and they put those together into a sort of report on what's happening in the civil contingency side during the pandemic, and made that public and also available to the government.
Thank you. I'd mentioned that we were going to come on to discuss health services framework and preparedness, but since you've mentioned it, perhaps we could talk about public health leadership roles for a moment. And I think, Dr. Tegnell, could you please explain the role and extent of the authority of the communicable disease officer in each region, including how their independence is exercised in practice, and whether or not they're part of the public health agency?
The regions have an obligation by law to put in place a communicable disease officer who is actually an agency, a legal agency in itself. And the size of it differs, of course, because the regional size differs from like 60,000 people to some 2.5 million people. So sometimes it's 1 or 2 persons and sometimes it's a whole group. But there is one person who has this sort of legal mandate to be the communicable disease officer. The mandate mainly implies that when you do test and trace activity and the persons that you trace are not following the rules of the physician, because the test and trace obligation lies with the health system, not with the communicable disease officer. But she can step in when the persons do not abide by the rules and so on given by the physician in charge. And they can even contact the police and so on to enforce certain restrictions and stuff like that. So that's the legal role. Then, of course, he has a kind of advisory, coordinating role in improving the communicable disease control within his region. And
what is the relationship with the region?
From the national level, you mean?
No, with the region, the communicable diseases officer in each region. What is the relationship with the
person is put in place by the region, but independent from the region. We have had a lengthy discussion where they should sort of sit in the system. But when you come down to sort of the legal point of it, it's definitely this person is independent and takes his own decisions outside of the region, and has a kind of supervisory role, I would say, both in communicable disease control within the hospitals, but also outside of the hospitals.
The Corona Commission, I think, had commented that the system of communicable disease prevention and control was and is decentralized and fragmented in a way that makes it unclear who has overall responsibility when the country is hit by a serious infectious disease. Do you have any comments on that observation?
It is true to a certain extent, I would say, because the Communicable Disease Act is very much focusing on the individual and very much focusing on sort of test and trace around the individual and those kind of aspects. So it has a very much of a focus on that, and that's historically because the Act was very much developed during early HIV days. Mm-hmm. So this was very much in the minds of people in those days, and that's really what the Act focused on. It is not very well adapted to a mass casualty, mass situation, and that is taken care of right now because we have an inquiry ongoing looking into how can we further develop the Communicable Disease Act to be more focused also on these mass events. This time we had to rely on a number of other laws to be able to do what we needed to do during the pandemic.
Dr. Tegnell, in Sweden, the Communicable Diseases Act 2004, which you've already referred to, provided a framework, but was also focused on the individual rather than society. It sounds not too dissimilar to New Zealand's legislation. Could you please explain the extent to which this and other legislation allowed for a response to the COVID-19 pandemic in Sweden, and in particular whether they were sufficient to enable infection prevention control measures to be initiated or, like in New Zealand, a state of emergency to be declared?
Well, let's start with the last one. It's not possible in Sweden to declare a state of emergency. That kind of change of mandate is not within the legal system. And as I said, the whole system in Sweden builds on that you have the responsibility that you have in peacetime, and your responsibility is really to keep on running whatever services you are obliged to in peacetime, also during a crisis. And each actor really has a responsibility to build up a system to be able to do that in different ways. So that's the basis for that. Yeah, as I said, the Communicable Disease Act is very much an act that deals with handling the individual and smaller outbreaks, not for the big ones. And that was discussed a lot, and eventually there was a pandemic law passed in Sweden to give. That was not used basically at all, I would say.
Are you referring to, there was temporary emergency laws in spring of 2020,
yeah.
and then the Pandemic Act in January 2021.
Yeah.
And then I think there were amendments to the Temporary Infection Control Measures at Restaurants and Bars
yeah.
Act, which is quite a mouthful.
Yeah. So what happened instead was that we made provisions in existing acts in other areas, for example, when it comes to restaurants, which are very heavily regulated in Sweden when it comes through our alcohol legislation. So that was used as a basis for regulating the restaurants. Big gatherings were instead regulated through other acts. I think in the aftermath we all agreed that this was not a very efficient way of doing it because it became too blunt. We couldn't make the adjustment to different kind of services and different kind of big meetings and so on that we thought were necessary. For example, religious services and so on ended up under the same act, which didn't really make much sense. So, and that's why we had this ongoing inquiry to look into what kind of other legal measures do we need to have in place to be able to be more focused when it comes to regulating different parts of the society next time. And
you touched on it, so Ashley, but we'll come back to in more detail later. But just while we're on this, Dr. Tegnell, how are the restrictions that were legislated? Although I appreciate you say they weren't used that much, but how were they restrictions that were legislated or recommended enforced?
They were enforced to, I mean, if we take the restaurants as an example, they were enforced during the normal system, which means that the county boards, apart from the regions and the communities, we also have counties, which are a kind of coordinating role for the communities. So the county boards then have an inspection role when it comes to that the restaurants actually follow the rules that are in place. And that role, together with the communities, they also had during this. So when there was a change in legislation for the restaurants, they had to go and inspect. And those powers, they can close down a restaurant if they don't feel that they follow the rules and regulations in place. So that was the system that was also used in this instance for regulating the restaurants. When it comes to big gatherings, that goes back to a law that the police handles about allowing big gatherings. And every time you have a big gathering in Sweden, you need the police to ask the police for permission to do that. And so that was, since the police did not give permission to big gatherings anymore, because that's what the new regulations said, they also were the ones to enforce that it did not happen. As I said before, I mean, the health system is federal, I would say, in the 21 different regions who, of course, has a general mandate to do certain things, but do it in a slightly different manner. And to a certain extent, that, of course, makes sense. You run a healthcare service different in a remote area up in the north of Sweden with maybe a population of 1 person per square kilometer compared to Stockholm. You have to run one for 2-3 million people. So there is strength in it, of course, but also problems when you have bigger common problems. So that's, I'm going to come back to that. The health services is also, one of the problems I would say is that some 40-50 years ago there was a division in obligations between the communities and the regions, and the long-term care was moved from the hospital sector to the communities and became a kind of social service instead of a health service. And can
I just pause there? When you say long-term care, what are you referring to?
Yeah, any kind of elderly care, any kind of even medical care for providing a place for people with long-term problems, a place to live and so on. the system in Sweden has also been very much pushing for home care. So the number of beds have been diminishing rather drastically over the years. So we have been, compared to most other countries, we have very, very few hospital beds, partly compensated by that the communities run what in other countries probably would be said to be a long-term care facility. But the communication between the two are very varying, and actually the communities are not even by law allowed to employ doctors to run these services. They are run by nurses to a certain extent, but mainly by people in social care. So that's definitely a weakness that was well documented and well known, and we all were quite worried about what's going to happen to these kind of elderly homes in Sweden during a crisis like this one, because we knew from flu and so on that they were really very open to having big problems doing that. And they are really catering, since home care is pushed so much, these are the people who are really very old, very frail, and very sick. And I think the mean survival time after moving into a home like that is somewhere between 6 and 8 months. So these are, and it's only like 10,000 people living there out of 2 million people above 65 and so on. So it's a very, and it also proved to be a big problem, and we can come back to that. So that's one of the problems in the system. The other problem is, as I said, that the number of beds have gone down. We have a problem with staffing, as you said. We don't have problem with beds, actually. We have problem, especially nurses who don't feel that the regions are very good employers, so they tend to go into private to move to other countries like Norway and so on. So this is a big problem. We have also, relative to most other countries in Europe, fewer intensive care beds. But since the system is very much in one hand in each region, there was a possibility to actually compensate for that, and establishing, actually we doubled the amount of intensive care beds very, very quickly during the first spring. And it was done by moving staff from other services. So, not always very successful. My daughter is an intensive care physician. She tells me about that you cannot get orthopedic surgeons to work as nurse assistants in intensive care. It's not the way to go. So a lot of learnings from that. But intensive care actually managed to help this. And we had always open place in intensive care in Sweden. But that was also very much because quite a lot of elective surgery and so on was pushed off, because the other problem in Swedish healthcare is the long waiting times we have for elective care, like hip replacements and so on, which is continually discussed and not handled very well. Thirdly, when it comes to supplies, the Swedish healthcare system works on what I would call an IKEA system, which means that you don't have anything in stock anywhere. Everything is just on the road between different places. And this, of course, works very well in peacetime, but proved to be a huge problem during this time. So that really also a thing that we knew about and we had reviewed repeatedly, but not really taken care of, mainly because there was a big discussion between the national level and the regional level, who should take the cost for setting up this. So this was really a fight in the beginning to be able to get face masks and all these kind of things in place, because there was not really the system in place so that you could have those. So there was a lot of challenges, but at the end, the Swedish health system does in peacetime, just like New Zealand, delivers extremely good care. I mean, the outcome of cancer treatments and so on is really top-notch. And actually managed to continue to do that through the pandemic. And I think they can be really proud about that. They managed both to take care of the COVID patients, but also managed to give reasonable care to the rest of the patients.
Thank you. And then also to ask you about the health of your nation and to what extent that was a vulnerability or not, the general health.
I think we are quite comparable to New Zealand. We have a very high level of the average age in Sweden is very high, especially among men. We had a rather surprising development that increase of average age of men has moved on, while women has leveled off. And we don't quite understand why. There's quite a lot of discussion about that. And I would say in general the population is very healthy. The number of unhealthy years towards the end of your life is very low in Sweden, which I think is even more important than average year. And it has, in spite of that, average age has increased. The number of unhealthy years has kept very stable over the years, which shows that it's a very healthy population on the average and on large. But as in New Zealand, we have a small minority of people who fall behind for a number of different reasons, socioeconomic, different handicaps and so on. And that part of the population is falling behind even more. So our health equity is increasing. And it increased even more during the pandemic because those groups were hit much, much worse. We could see that among our migrants being born or having parents being born in Somalia and living in Sweden, your risk of getting into an ICU was 7 times higher than a comparable person born in Sweden or with Swedish parents. So those groups really suffered.
Yeah.
Let's just start with the context, because I mean there are many similarities between New Zealand and Sweden, but there is also huge differences. I mean, Sweden is part of the Nordic region. We have had open borders for the last almost 100 years, no passports, nothing. So a lot of people move across the borders all the time. Just in the south of Sweden, more than 60,000 people commute every day between Sweden and Denmark and live in one. And so. And the other thing that happened was that this pandemic started in Europe during our winter holidays. 10% of the Swedish population go abroad. So 1 million people come back within a week or two, mainly into our big cities. So we had the policy on containment for the first few months and managed that reasonably well. We caught a number of cases during that, and help of testing and tracing, we did not see any spread. But when these 1 million people came back with the disease from all over the place, basically, our system was quickly overwhelmed, and there was no way that we could handle the containment anymore. We had so much spread, especially in Stockholm, in the surrounding area, but also in other parts of the country. So that was why we shifted. And that was very much a decision taken after hearing from our regions that there is no way we can both test and trace 1 million people and take care of a rising number of cases in our hospitals. There are limits to how much we can do at the same time. You can always discuss who took the lead or not. I mean, as I said, I consider that we had the same division of labor like we do normally, but that means that when it comes to technical matter, and this remained a technical matter to a great extent in Sweden, the Public Health Agency, together with the National Board of Health and Welfare and MSB, were the ones that sort of were mostly seen, were the ones who sort of told what's happening and also gave ideas what we can do about it. And I think, and that's discussed quite a lot right now in Sweden, I think that we were a broad public health agency and that we work together with other agencies normally also very much did that our response was not solely focused on stopping the spread, but very much focused on protecting vulnerable groups, protecting our health services, and not least protecting other services in society so our society could keep on functioning. Because we understood once we were overwhelmed that this pandemic we're not going to be able to stop it. There's absolutely no way we can do that. And it's going to last. And as I've often said in interviews, this is not a sprint, it's a marathon. And we need to have things in place that people can live with. And our government was very much in agreement with that. We need to find a way out of this that's not going to destroy more than it helps.
And what made you so confident, and I'll invite Sashi to comment as well, that it was going to last as long as it did?
I mean, historical evidence is very clear. Once you have the establishment of a disease on that kind of level, you can maybe stamp it out in isolated regions, but not on a global level. There is no way we can do that. So we had a new disease, and that disease is not going to go away by itself. It has happened in history. SARS disappeared, but that was the exception. The normal thing that we all know from history is that these diseases are going to stay. And our pandemic has normally been years. So why should this one be so much shorter?
Dr. Tegnell, if you could just explain briefly the containment approach and how it can be characterized in contrast with the elimination approach.
Or rather, the mitigation approach, which is basically the classical pandemic strategy of trying to flatten the curve. Because once you have sort of realized that you have an ongoing spread of the new disease in your country, and you have sort of decided we cannot stop it because it's just too big. Our main goal was really to try to get the curve as flat as possible, to not having a health services that was overwhelmed or too much spread to people who could not protect themselves and so on. And we worked with that in different ways. We did regulate many of the kind of restaurants, big events and stuff like that to diminish or close them down completely, but to diminish the meeting points. Because what we are all then trying to do, and we discussed it also this morning, it's all about getting people to meet fewer people every day. And so in many ways we did similar things with New Zealand, but less drastic, if I may say so, because our goal was not really to stop it completely, but to get the famous R0 down as low as possible. And we did that very much by focusing on places where we could see that we had a lot of spread. We knew we had a lot of spread in the workplace. So we told people to work from home as much as possible, and we told employees make it possible to work from home. And that worked. 50% of the Swedish population work from home, which is, again, context. You can't do that in any country, but in Sweden we can do that. We also told people, if you have symptoms in the morning that could be COVID, any kind of symptoms, stay home and wait and see what happens. And we changed the insurance way so that you got compensated from the first day, so people could actually stay home from the first day. And we also told people, please go out and meet people outside, but see to it that you're always keeping a distance. If you're going into a store, the store was told that according to how many square meters you have, you can only have so many people in the store at one time. So you need to have a system to sort of see to it that you don't have more. So all of these kind of things to try to find the places where there was a risk of spread and regulate them, but to let other things go on. We could, for example, find out by local studies that gyms was not a problem. We did some interesting, because we have so many registers, we could see that people actually going to gyms were not really at harm at all. So we said, please keep the gyms open. And we could see that different kind of training grounds for children and so on was not really a problem. So we said to the communities, keep those open. The kids need to be able to be outside. So I think that's really what we try to work with. We try to work with the data we had so that we could find the places where there was a risk of spread and regulate those, but to leave as much of the rest. And by that, getting the R0 down, getting the curve flatter, making it possible for our health services to keep on running good services for everybody. We probably going to come back to, we had a problem with testing because our testing capacity, especially in the beginning, was far from what we wanted it to be. And that's what part of the reason why we told people to, if you have symptoms, stay home. We don't have really capacity to test all of you, but so stay home instead, and after 24 hours it probably figures out if this is because of the beer you drank last night or if it's COVID.
Thank you, and we will come back to testing, definitely.
I think on a global level, almost all our plans were more or less openly based on flu, because that was what we knew in a modern society. That's the kind of pandemic we've had during the last 100 years. Even if there have been blips with SARS and other things that could have constituted something. On the other hand, I must say that especially after both the H5N1 spread, I don't know how much that was, it was quite an issue in Europe and in Sweden. And after the swine flu pandemic, we had quite a lot of discussion on that it needs to be flexible. Because even a flu pandemic, if you look at the flu pandemics we've been living through, they have been very, very different. So there was definitely a need for flexibility. And on top of that, we also had the experience from the terror incidents with anthrax and so on. That was also a part of sort of what we had in the back of our head. So I think we had quite a lot of discussions on flexibility and try to build that into it. But, I mean, we did not cover. I don't think we really realized that it's going to be so different in many ways. Even if it in many ways, of course, is also very similar. We're talking about a respiratory disease. It's spread in similar ways in similar places and so on. So there's a lot of similarities that we could use. So maybe at least to some extent, it was the restrictions we took and the decisions we took that were more different than from any previous pandemic than anything else. And that in itself constituted, of course, a problem how to handle that in a reasonable manner. So I would say that, yes, it was very good that these plans were in place. There were a whole of government approach built into them, even if that was not, I mean, it really developed much, much further during the pandemic. And I think that's definitely a lesson we take with us, that a whole of government approach might sound like one thing, but in practice, this was much, much bigger. And I usually say I have not talked to so many different parts of Swedish society ever before, like I did during this time, because everybody wanted to understand what does this mean for me. And I think it's really an eye-opener for many parts of the society, not least the non-governmental parts, which I think we really need to foster and keep on, because it's going to be very useful for public health in the future too. And we had a national pandemic committee in place, so we met with what we consider to be the essential services, and that was the veterinary side, it was the agricultural side, it was of course, our medical product agency, the contingency agency, and a few others that met once a year to discuss, okay, what is the threat right now, how are we developing our plans further, what kind of exercises and so on we're doing. So there was a lot of connections in place already.
And that was pre-pandemic, was it?
That was pre-pandemic. That started already, it started after the H5N1 that we had those meetings. And then, I mean, Sweden is part of EU. We are part of the Nordic region. Especially the EU had worked quite a lot on this. I had myself been working as a seconded expert in the Commission with developing these kind of contingency plans, and very much discussing also that we need to have a generic plan that can take care of many different things.
Thank you. Dr. Tegnell, at what measures did the national plan in Sweden contemplate, for example, border closures, quarantine or masks?
Nothing about masks, I would say. Quarantine does exist. That in our Communicable Disease Act there is regulations for how, by the decision of the director of the Public Health Agency, we can close off certain geographical areas in Sweden if there is a need to do that. So that was there. On borders, yes, according to IHR, there is even a special law in Sweden when it comes to international communicable disease control, which gives the provisions for what we need to have in place along borders to be able to handle importations and stuff like that. So that was in the plan, but not border closures to the extent that we talk about now, more about how can you regulate borders, how can you divert ships and airplanes to the right places so that you can take care of the people on board that might be sick and so on. So it's a different kind of border closures than the ones that were actually used in the end.
Thank you. And what was the extent of planning at the regional level, and did the template that's referred to for regional pre-pandemic plans that was supplied by the national level authority refer to social care, for example, including for care for the elderly?
Yeah, I mean, the operational responsibility was at the regional level to a very great extent. Almost everything we talk about was supposed to happen there. So the regions were also by law obliged to have a contingency plan. And for all of them, now when, not if you go like 10, 20 years back, there was more generic contingency plan, but after both the H5N1, SARS, and the swine flu, all of them also had developed specific pandemic plans according to the template that we had provided to them. And we also had common exercises with them, both with them and also with other countries, and also collected those plans and did reviews of them. So there's quite a lot of communications around those plans.
And specifically, do you know whether they referred to care, social care, including care for the elderly specifically? Was that covered in those in the national plan template?
The relations between the regions and the communities when it comes to the elderly homes are very different in different parts, and sometimes regulated and sometimes not regulated. They are basically focusing on providing good health protection in those places, what kind of protective equipment and so on you need to take care. I would not say that any of them really dealt very deeply with what to do during this kind of crisis. Of course, there were writings about how to establish cohorts in those places and those kind of things. But then you need to remember that the operational plans were then the responsibilities of the elderly homes. And that we knew because also that had been discussed and quite a lot of discussion with the communities about their need to also develop similar kind of plans, but they were far less developed than what had been done at the regional level. So that was really a weakness in the system, and that many of those did not really have any practical plans in place. What did exist in most places were some kind of connections when it comes to hospital hygiene procedures and so on, to help them to choose the right kind of face masks and other things like that. Yes, I mean, the plans did not really specify them very much, but it specified very clearly that the importance of finding the vulnerable groups and act to protect them. I mean, that was a very, very important part of it. And also, during the pandemic, it was something that was very, very much in our minds. And we did a lot of analytics using the registries we have in Sweden to try to find those groups in different ways. And many of them, yeah, so we really learned a lot of that. And both that some groups were very much at risk, but also that some groups that felt themselves being at risk were not at risk. Teachers, for example, because the teachers were quite worried about having to go to school and meet all these kids. But since we had these registers, we could run and see that teachers were not at risk. And if they were at risk, it was because they met each other, not because they met the kids. So it was very useful in both identifying who we did protect, but also trying to alleviate the fear in certain groups that they were not really at risk. So this is, as my colleague said, very important of the pandemic plan is to try to find those groups as early on and protect them very clearly. And the Swedish analytics showed really very, very clearly that at risk was the elderly. Everything else was completely secondary. Chronic diseases, not very much. And also homeless, for some reason, were more or less protected. So there were some interesting aspects to it that we did not really suspect. But the elderly came through. It was very, very clear, a risk group. And
Dr. Tegnell in Sweden.
Yeah, I mean, with because we are coming back to the civil contingency laws and regulations around that, and those laws and regulations are very clear about that you need to keep on providing the services also in a crisis. The big discussion we had is what are essential services, because that's a very, very difficult subject to approach and how to deal with it. And I would say that what we focused on was a big loss of people, so that the services could not be supplied because people were not available because they were sick or something else. So this was sort of the kind of scenario we gave to them, and mainly to our contingency agency to work with. But there was a big problem in trying to sort of say who are essential services. And mainly we're coming back to you need to work with business continuity, keep the thing. So it came down to the individual services. You need to understand how many people you need to have in place to be able to run your services, and how can you redeploy the people to actually manage that. And I think that in most instances that worked reasonably well, probably because we didn't close down completely, so there was no loss of people because of that, and that people in working age groups were not sick all that much, that we had sort of anticipated to a certain extent, so that people were available and could be redeployed in a way that I think we're also trying to measure the impact on chronic care and so on. We cannot really see that we lost very much. Our average age went down for a few months during the first year, but then very quickly came up again. And our the extra deaths during this 3-year period in Sweden was minimal. So our health services, I think, even if we haven't looked at the specifics very much, seems to have been able to deliver. And also the services to disabled and so on were very much kept in place. So it, even if, somehow, sometimes probably diminished to a certain extent, but it's since the responsibility is so divided, so it's very difficult to make any kind of analytics of it. But if you look at the outcome, it looks reasonably well. I must say I don't completely agree with the statement, and I don't know what to base it on, because we did make collection of plans, and we found plans everywhere and reasonably often updated. When it comes to exercises, not as much. I think the health services do a fair amount of exercises, but they are mainly focused on catastrophic events, like a big train crash or something like that. And they do that reasonably often, and they do it very well, and they handle those kind of crises also very well, because it's very much these kind of long-term crises that we had this time is very different and also very difficult to exercise in a meaningful manner. So that had not happened very much. We do a number of exercises, both because we do them nationally, very infrequent, I must say, but there's also initiative from the EU level, so we're also involved in those kind of exercises. But mostly in a fairly small group of agencies and so on. So this kind of whole of government testing and so on is done very infrequent. I agree with that. But they are not completely easy to do. We often tend to try to exercise a certain part of it, like the startup of things, or things like that, to make it manageable. Probably the most useful part was that the development of them meant that we had a kind of network in place, that we had talked about this, and we had met with other agencies also involved. We had quite a lot of meetings together with the medical officers out in the regions around it. So we knew who we should talk to. And I think that was the most important part. And some initial things like the testing and tracing in the very early pandemic, those kind of systems were very much in place. But after a while, we tended to go much more into sort of trying to use our data to see how do we deal with this in the best possible manner, where are we going, and what can we possibly do to make it as reasonable as we can.
Thank you.
I'm not completely sure what the Commission means about dismantling earlier stockpiles, because the earlier stockpiles were really stockpiles for war.
Okay.
They were dismantled because they were not really useful anymore. We had, for example, drums of chloramphenicol. Chloramphenicol is an antibiotic that's not used anymore because it has side effects, and they were in drums. So these kind of things exist, and they also were respirators from the 50s and stuff like that. So most of these things were not very useful and meant for a completely different kind of situation. So the dismantling of those, I think, really didn't have anything to do with the main problem, which I was alluded to earlier on, that nobody kept stockpiles. And we had, I think, at least 3 different government reviews over the years looking into this and saying that we really need to do something about this, but nothing really happened. Partly because of the reason that, from a legal perspective, the responsibility lies with the regions. But the regions did not really agree with that. They thought that, okay, in this kind of crisis we're talking about, we need the government, the national government, to be more of at least financer of those kind of things. And they were never even, unfortunately, never really able to reach a consensus on how to handle this until now. So there were no stockpiles anywhere, and even the agreements with suppliers did not really provide for any stockpiles at their level, which sometimes I think is maybe even better than running your own stockpiles to get your providers to keep stockpiles, because you don't want things to get old. So you need to really have a revolving stockpiles, and so not that easy always. I mean, you don't buy 1 million mouth coverings and say that now we have fixed this. This is much more of an operational thing that you need to keep on running. I think we learned a lesson, at least to a certain extent. The regions have taken a completely different kind of responsibility in this and started building up, both having agreements and actual stockpiles in place. So the situation is much better. And I know that we have current reviews ongoing if we should do something like what they do in Finland, where they have a law in place saying that you need to keep, I think it's 3 to 6 months stockpile of any things like this if you run a healthcare, if you run a hospital.
Dr. Tegnell, toward
No, I think the situation in Sweden was very similar to when it was mainly a health service kind of thing, and it was mainly the hospitals who used them and had them to a certain extent, sometimes in the elder care, but they neither had the structures in place, nor the training in place, nor the stocks in place to use them to an extent they should. So this was really a big problem. We never really saw the use of face masks out in public in general, even if we could sort of see that there might be certain places at certain times they can be useful. But I mean, it's a complicated matter, and not least the volumes you end up needing is going to be astronomical if you're going to use them in the right way. I did a quick calculation. We talk about 1 billion masks a month in Sweden if you use them as you should. And I think our experience in Europe is that, yes, masks were all over the place, but very seldom here. So I think if we want to have the good use of them, we need also to rethink our strategies and how to use them, and also, once again, try to find out where do they actually make the most use, so we don't end up telling people that you go out for your morning run, you need to have a mask on. So it also needs to make sense to people that, okay, if you need to take a bus that's already full, yeah, sure, then it might make a difference. But if you take your bicycle to work, you don't need it. So I think, once again, we need to work more on that.
Thank you very much.
Yeah, I think we talked about it a little bit already, but we also had different levels of response to a pandemic in our original plans, but I think the difference is that we went all the way to the top at once. So we never went back until the whole thing stopped. So there was never really any question about where we were. We always had a community transmission, and we needed to mitigate that as much as possible. So this was, I think, slightly different from the experience in New Zealand. There was no question about that. And there has been some discussion, I think, this internationally, about that there was legal. We didn't really have the legal possibilities to do certain things. I don't think that was really important, because we never really went that far that we really asked the government for. Because, I mean, of course, we could have had a new law in place if we thought it was necessary, and the government agreed with that. And I think we shouldn't overestimate what that did to sort of steer the response. I think we had a kind of two-level response. We tried to regulate businesses and restaurants and big events and so on as much as possible, but doing so in a very close communication with them, so that we could find something. And I think that was especially very clear when it came to restaurants, that we could find solutions that would both fulfill our goal of having people meeting each other less, keeping in the bubble. I mean, we didn't officially talk about the bubble in the same way, but it was interpreted in that way. So many people in Sweden also live within their bubble. And going to the restaurants in your bubble and not sort of meeting any other bubble, we didn't really see that as a problem. So, and if the restaurants could sort of cater to that, to see to it that you could stay in your bubble, we thought it was okay to keep open. And they gave us good ideas on how to do that. So I think, and that's sort of really very much the way we worked. We tried to find different areas where we did see problems, and then we sat down with them and talked to them about what can we do to alleviate the problem with the spread that you have in your place. I mean, workplaces, can people work from home? See to it that they can do that. If they need to go to work, see to it that you put up your structures in place so that people can stay in their bubble at work too. So it was not a staged response in that way. It was more a response based on the development of the epi situation. When we saw that we were heading into something that was worse, we tried to find, okay, what more can we possibly do? And then try to sort of put that in place.
And in terms of the trust that Sir Ashley spoke about, to what extent did that factor into either the decision to adopt the approach or the compliance levels?
You mean the trust?
The trust, yes.
Enormously, I would say. But also because this was not new to us. I mean, Sweden is to a great extent a trust society. It's very much built on trust. We don't really have much legal provisions in place in many places. And for example, even an oral agreement to buy or sell something is considered legally binding. It does not need to be put on papers. It does not need 5 lawyers to help you sign it. And that is very much, I mean, there are, of course, parts of society where it is, but for majority of society this works. And the level of trust in institutions is very, very high when you measure it in different ways. And it has been for a long time, especially, and for the Public Health Agency, it increased during the pandemic. There was even measures about the level of trust in me personally, which I thought was a bit strange, but even that went up. And we also did this kind of thing, went out to ask people about, did you change your way of living and so on? 80-90% constantly said yes. We did change the way. And I think you spoke very well about what you need to have trust. And I think it's all very much the same kind of things. It's also transparency and talking to people in a way to get them to understand why you're asking them to do things. We were very much working with trying to sort of say, this is what we're trying to achieve. We do realize that we all have different lives. We are trying to get you to meet fewer people. Think about what you can do. Here are some ideas. Work from home. Stay at home when you're sick and so on. Don't take the subway. Take the bicycle to work. And so everyone could sort of choose, this is going to work for me. I'm going to do my part. And I think the loyalty to that was amazing. We talk so very much about everybody being individuals these days in our societies, but when it sort of comes down to this, and I think the experience to New Zealand is the same, suddenly people feel that, okay, I can do this. Even if I think people in Sweden were very well aware of that, most of us, we can get COVID, it doesn't really matter. It's going to be like another flu. I'm not going to, but I can do that for my elderly or whatever. And I think that it feels sort of nice to have been through something when people actually came together and really believed in that we can handle this.
Definitely. Well, thank you very much. The last question I have for you under this heading is just the approach that Sweden took, just generally in relation to measures. Was that taken at a national level, or did it vary by region?
Yeah, that's quite interesting, because normally our regions have very strong ideas on how they want to do things. So we thought, okay, now we're going to give them a kind of table with different things they can do, and they can choose themselves what they think is adequate to do right now. Different kind of. But very, very quickly they came back to us and told us, no, this is not going to work. This is going to be too complicated, and we're going to spend too much time trying to tell people why we choose that and not that and so on. We want to have a nationwide strategy that's going to work everywhere, even if we knew that, especially in the beginning, the spread of the virus was enormously different in different parts of Sweden. Stockholm took the brunt during the first wave. Malmö in the south had almost nothing. They had less spread than they had in Copenhagen. But even so, the people from the different regions came back and said we prefer to do it jointly, because we think communication-wise it's the only way we can handle it.
That's interesting. Well, thank you. Dr. Tegnell, to what extent do you consider that it was applied in Sweden? Oh, well, first of all, your understanding, does it accord with Sir Ashley's of what it is?
Partly, but it is a tricky subject, and you can interpret it different ways, and it's used differently in different circumstances and so on. So I think it's difficult. We never used that term ourselves, but we were sort of accused of not using it, and I don't completely agree with that. I mean, legally, in the Swedish context, the precautionary principle only exists in our environmental law. That's the only place where you can find it. And there it very clearly says you're not allowed to do something that you cannot prove is not harmful. So that's sort of really coming from the other side. So I think we relied much more on the issue of proportionality. You're not really allowed to do something that's going to hurt people if you can find another way to do it that's not as hurtful. And I think that's really what we worked with. But at the same time, I think in public health, we are very used to taking decisions on not complete scientific evidence, because it very rarely exists in public health in many areas, especially not when you have an evolving situation. So I don't think we ever had a problem with taking decisions that was not scientifically valid. I mean, we took a decision that we thought was based on the best available evidence at that time. For me, that's a much better term. And then maybe sometimes we had to change, because more evidence, more science turned up, and it turned up that the best available evidence at that knowledge at that stage was not the correct one. And I think we worked much more along the proportionality and best available evidence or knowledge at one stage. That was our leading things, and not. We never really internally discussed the precautionary principle. It was more the people from the outside who criticized us, who said we were not precautionary enough. We definitely thought we were as precautionary as we possibly could be in the situation where we did exist. Because I completely agree, having a lockdown at the wrong time is counterproductive. And we were definitely past where you could use those measures very, very quickly. And I think a lot of people didn't completely understand that. I mean, we have an extensive amount of registries in Sweden. And we have personal identifiers, which means that we can, on individual level, collect different registries. This does not mean that it's easy to do that. I mean, technically it's very easy, but legally it's not. So there's very stringent systems around this, when you're allowed to do it and when you're not. So we shouldn't sort of really think that we could just run around doing it any way we wanted. We really went through all these different kind of things to really show that ethically and legally we did things that we were allowed to do. So data became very important for us, also because our registers are fairly fast. We do get report on new cases within 24 hours. We do get information about deaths within 2 days, at the very most. So we had very, very quick data and very, very complete data.
And just, sorry to pause you there, just you spoke about the personal identifier number. Could you please explain a bit how that is, how that works, how that's traced,
each
and if that's
Swedish citizen or each person living in Sweden eventually would, at birth or whenever they enter the system, get a personal identifier, which is basically your birth date plus four digits in the end. And that is an identifier you use in any possible circumstance you can think about. If you go and rent books, or if you borrow books from the library, you would use it. If you go and buy food and you're a constant customer, that is also the way, and it's also used in all official registries. So this is the same number is used all over. So it means that we can at least in theory follow a citizen through our system very, very closely, and we have actually we do have a lot of collection of data where we can actually simulate this whole Swedish population and see where they work, where their schools, where their children go to school, and so on. So we can do a lot of modeling things on in a very real kind of, but still imaginary world. So they are really a fantastic instrument in many ways, and so we could use those data to follow very closely development, both on the number of cases and deaths, and also where those deaths took place, among age groups, geographically, if they were in elderly homes, what kind of profession they had, and so on. So we could constantly follow and see what were the risks right now and where do they exist, both geographically and in different parts of the population. On top of that, we got a lot of suddenly, we got the possibility to get data from many other providers also. So we got data from our mobile phone providers. We could follow how Swedes changed their mobility patterns because there was a lot of data on that. We could get data from the metros in Sweden to see how many people actually travel with metro every day. So there was plenty of other data that we could also use to sort of, I would say, mainly to follow how well people adhere to our recommendations. I mean, that was a big part of it. And I think that was also a big part of the trust and the level of people actually followed it, because we could give them feedback. Sort of telling a child how good you are, you're actually doing what I'm telling you. And this, I don't know if we haven't really studied it, of course, and it's not, I don't think it's possible to study, but I think it had a great part of that people actually kept on following our advice, that they could sort of see that we can see that you are actually following our advice, and you can also see that following our advice actually makes a difference. So, I mean, you can use data in many different ways. We also used it very much in a modeling sense to give our hospitals an idea about what can you expect during the next 3 or 4 weeks. Is there going to be more cases or less cases? And that was very, very important for them, because I mean, they had made big transitions in establishing more intensive care beds, and they needed to understand, are we going to push this further, or can we possibly slow down a bit and maybe do other things?
And was that based on infection rates testing results?
That was based on what had happened in the past. It was also based on the prevalence in the population. We did big prevalence studies with a few months in between, where we went out and randomly tested people, so we had a good idea of the prevalence of the infection at any given time. And it was also based on what we knew about immunity in the population, and eventually also vaccination coverage and so on. And eventually our modelers got really good at this, and we could, once again, we did it afterwards. We also told people how good were we last time. So we developed this every other month. And then all the time we also went back, okay, last time we did this well. Actually, we were reasonably sure about it. And we always gave them 3 different possibilities. If everything goes really, really well, it's going to be like this. If what we really think is going to happen, this is it. And if it goes bad, it's going to be so somewhere in between these 3. But most likely it's going to follow on in general. To really give people an idea of that this is not cut in stone. This is what we think is going to happen, and you need to treat it like that.
And you mentioned the various uses that the data was put to. Was it used to inform, I think you've mentioned this already, who was most at risk and who ought to be prioritised for vaccine? Were those included?
Eventually it was also used for that, yeah.
And to what extent was disaggregated data, for example, by gender, age, socioeconomic status, used to inform decisions?
I mean, I would say it was, because it, to a certain extent, told us where our communication works and where it doesn't. So that initiated quite a close collaboration with the regions and the communities in trying to reach our hard-to-reach populations, which does exist, spread all over Sweden. But most communities and regions are quite well aware of where there are sort of pockets of these kind of groups. And we had quite a lot of discussions with them how to reach them better with communication, and how to reach them better with the vaccine offers once they came. So that were definitely very, very important.
And I think you've already touched on this in the context of teachers, but did the collection of citizens' data relating to the risk of disease by occupation type allow targeted interventions on the basis of occupation type?
Yeah, it took us away from doing that, I would say. So we went back and said that, no, we need to focus on the elderly and also people who have a lot of contacts with different kind of support services. So people with disabilities and stuff like that ended up in that group, because we didn't really see that they got sick much more than anybody else, but the risk, since they meet so many people every day, was higher. So we could sort of steer the initial doses of vaccines very much to those groups, and to a fair bit not steering them to health personnel and others that maybe felt themselves being at more risk, but we could show from our data, no, they are not really at more risk. And we had some quite heavy discussions with the regions around this, because the regions really wanted to have their people vaccinated. Not so much because they believed us when we said they're not going to get sick and die very often, but they still wanted to have their people at work. And I think that's still an ethical question that we're struggling with. But the ethical platform from the Swedish Parliament is very clear about that it's anything from a health service should be directed to the people that most need first. So other kind of things need to be second to that.
And you mentioned, I think, collecting data on deaths. Did Sweden collect data in respect of the mortality of vulnerable groups, such as those with profound intellectual and multiple disabilities, before, during, and after the pandemic?
Yeah, we collected deaths according to a lot of different groups. I'm not sure we collected exactly for this, but I'm pretty sure we did for people with disabilities. I mean, in Sweden, the registries give us possibilities to see that through that there are registers in people who get social support. Through those registers we could see that. And as far as I remember, we didn't really have an access in those groups, but we could follow mortality in lots of different groups.
And how was the number of deaths from COVID-19 measured in Sweden? For example, within 28 days of a positive COVID-19 test, or by some other measure?
No, we used the method of saying anybody who died and within 30 days had a positive COVID test is considered a COVID death until proven otherwise. Mm-hmm. So some were taken away because there had been a traffic accident and so on, but the majority. But what some researchers and regions did afterwards was to try to find out how relevant is this. Mm-hmm. And they went back into the hospital records and could see, okay, maybe about 50% of the deaths that we are recording according to this system is actually due to COVID. Another 50% is people dying with COVID. But that the official numbers we gave were the ones who had a positive COVID test and died within 30 days.
Thank you.
Just wastewater was also used in Sweden and in the EU. But since we were in a different situation, I mean, it was there all the time. We mainly wanted to use it for seeing that this was the start of a new wave. And I would say that then it did not provide any, it was not quicker than the results we got from testing and so on. So for that purpose, it was not useful. And now afterwards, we have done extensive reviews of that. And I think what the experts have landed in, yes, it's useful to see if a new variant is coming, but not so much for measuring prevalence or where the epi curve is going or something like that. But since you tend to catch so many different kind of viruses at the same time, it might be useful to find that you have an introduction of new variants, and that seems to be where the knowledge stands right now. And it was also tested, I think, in some places to test for wastewater from airplanes to sort of try to make some kind of judgment, but never really came out very much out of that.
Thank you.
I think maybe run a bit differently, but very similar. I mean, we had a number of different groups in the public health agencies working with school questions, elderly care questions, personal protective equipment, and that were mainly from within the agency, but many of them also had sort of contact points outside. So they had a network of hospital hygiene people and network of school people and so on. And so many technical areas like that were covered, but mainly by groups that were run by and initiated by the public health agency. Since it works slightly differently, we are then sort of collecting that and taking it on to the government. On the governmental level, they had this grouping I was talking about before, who regularly called the directors from the relevant agencies to come to them and give them information. We also had a very important group in meeting with the communicable disease officer in the different regions, and that twice weekly. And then we also had a more general expert group that was called together, I think monthly, or, depending a bit on the situation, with experts from communicable disease control from the hospitals and from virologists and so on, sort of gave us more widely a way we could sort of bounce off also new ideas on how to do things. Apart from that, as I said before, we met with many different kind of groups, union leaders, religious leaders, restaurant leaders, and so many groups like that we also had regular consultations with. So.
What was known or anticipated in relation to potential harms for the measures that you did or didn't ultimately take?
No, I mean, I concur. I think many of them were anticipated, but the quantity was unknown. We knew that a number of things was going to happen when you close school because, I mean, it's quite obvious, many of them. But to what extent? It's very difficult to understand completely, and also what would be the extent of on the economy and stuff like that. I mean, many people try to figure that out, but it was very, very difficult to understand. And we also put in compensatory mechanisms by supplying many firms and so on with extra money to help them survive. Maybe even overdoing it, because we have seen, at least in Sweden, that companies goes bankrupt after the pandemic who had probably gone bankrupt during the same period of time, but they've sort of survived due to this extra money that was supplied by the government. So, I mean, we could definitely discuss this is going to happen, but how bad is it going to be was something we needed to follow and to understand.
We've touched on, vulnerable groups in a few contexts. To what extent was it appreciated that there may be disproportionate impacts on particular groups because of intersecting inequalities, etc.? Was that something that was recognised going into the pandemic, the potential for that?
Well, I think all our experience in public health is that any kind of crisis would always hit our vulnerable groups more than anybody else. So I think, once again, it was definitely anticipated, but to what extent and how? Because maybe some of them suffered more from our restrictions than they suffered from the disease, and the other way around. Yeah, I mean, as an infectious disease physician, I know that post-infectious sequelae are not completely uncommon. It differs with different diseases, but it's definitely, when you have so many cases of a disease, it's not surprising that you see it coming up. Maybe we didn't, but it was very difficult to understand if it would, how much it would, and what it would look like. And I think we still have a problem trying to understand what this group is really about, because it's obviously a very heterogeneous group with many different reasons behind that they are now suffering afterwards, because suffering they definitely do, there's no question about that. And we are sometimes asked if this was calculated in as a possible risk and it would sort of steer decisions, and I would say no, because it was not difficult, it was not possible to calculate in any meaningful way, and we never really were there in our calculations. We did what we could to get the spread of the virus down as much as possible. And there was no really stopping that, except to see that any of the measures would harm more than do good. It was never calculated in how much it would sort of cost if we didn't do it, or so. To doing that kind of health economics was just not possible built on the data, and it would not really lead us anywhere useful at that stage. So we never really did those kind of calculations. We mainly looked at, okay, if we do this and this is going to happen, this is positive, we're going to get a slightly slower spread. But on the backside, it's going to get people more lonely and stuff like that. But to try to calculate in how much the cases would cost would have been impossible. And I think it's definitely a discussion we can have, but I'm not sure how it can ever be done better, I must say. These are things that it's going to happen when we have these big new outbreaks of some things. And we, especially during the first wave, we saw a number of rather strange manifestations of this disease that I think in those days really worried us, because if this is going to be true for the whole period, I mean, these not only post-COVID, but many other things would also occur. Unfortunately, the variants of the virus that came afterwards was much less likely to cause these kind of things, which probably also was less likely to cause post-COVID. But so the fear sort of was a bit less after a while. But there is always things with a new disease that you don't understand at first.
To what extent were implementers involved in feeding in and to decision making at the stage of deciding what restrictions to impose or lift?
Very much, I would say. The Swedish system is very much about getting wide consultations in society. So any kind of decision or any kind of similar document would always go out to a wide variety of stakeholders, implementers, or whatever you call them. So this also happened during the pandemic. It went a lot quicker and made people quite nervous that they needed to review a paper within a day when they usually have a month or two to do things. But the system kept being in place, and I think people really took it very seriously. As you said, I think taking these kinds of decisions were never done lightly. I mean, it was always many unknowns in it, and you need to weigh pros and cons, but you needed to take decisions, and I think that's what we all over the place really took decisions, because probably the worst decision is not to take one. It means that instead of using a classical modeling setup where you try to sort of recreate the society and the different people and populations in it, and see what happens when we introduce this and this, and see how that's going to go on in your sort of fake society with all the assumptions you make for that, which is sort of the classical way of modeling when you want to do it sort of really well in the academic world. We saw that that's not going to work, because there are too many unknowns of the different kind of variables that we put into that. So instead we went back and did more, I would say to some extent, what they do in meteorology. We looked at what has happened during the last 3 or 4 weeks. We add to that what we know about the present situation with immunity in the population, vaccination coverage, prevalence of the disease from other studies. And based on that and sort of our previous experiences, what's going to happen, we project, but for a very short period, only 2 or 3 weeks at the most. And doing that and learning sort of AI-like, but in the heads of people, we managed to get reasonably good at that, and we found that was the most efficient way of doing it.
Thank you.
Yeah, if you mean that the government now is looking into what kind of legal things we need to have in place, and also what kind of practical things we need to have in place to be able to do it in the future, yes. There was the agency to look into that. We have looked into it in the past too, and it is complicated, partly because of our regional system, because it would then be the regions who would have to sort of handle that, because they are the only ones that could handle it. And they, of course, are not too happy about getting that kind of responsibility, and the responsibility would be very uneven, because some regions have very heavy, it's going to have an incredibly heavy load, and others are not going to have anything at all. So it is a tricky question to put it up, and we have not really been able to, in the past, get any kind in place that seems reasonable. So we'll see what can be done, because it's, it's to a certain extent very much a question of volumes. And the volumes are quite different between Sweden and New Zealand. And also I think we, at least the way we interpret the law, we can never really prohibit somebody from coming back to their country. We cannot even delay it. So even if we don't have the resources to sort of put them anywhere, we cannot really stop that. And we all know that testing and so on at borders are never going to really provide any good protection. I mean, if you want to do it for real, you also need to put people in quarantine for a certain amount of time. And when you have big volumes doing that, it's a logistic problem to agree, and financial problem, because who is then going to pay these people? The loss of income and all of these kind of things. I mean, many people during the pandemic ended up having to spend a lot of money being quarantined in places where they could not, where they had to pay for it. So it's not easy.
No. And there were some border measures taken by Sweden. There was, or were there some border measures taken?
Yeah, there were border measures to a certain extent, together with all the other EU countries. We followed sort of when there was joint measures towards, for example, South Africa for a while, and for the UK and so for a while. So then we that did not really do that much because we don't really have direct, most of those times we did not really have direct flights or direct travel to those countries, so they would still have to go through another EU country before they came to Sweden. So it did not really put a lot of pressure on us. But it's tricky because, I mean, in Europe, most people come maybe to Frankfurt and then they go on another flight, and how are you going to be able to know where they came from? And I mean, it's the logistics around it is, in a place like EU with open borders and a lot of connections and people traveling by train, bus and car and bicycle, and I'm not sure that we ever can do anything about it. And I can still remember when EU put down saying that we should have restrictions against any country, there was always a long list of exemptions. And towards the end, those list of exemptions extended over 3, 4, 5 pages with all the different things that needed to come across our borders because there were essential goods or essential people and stuff like that. So it's complicated on many different levels. And can be done in a place like New Zealand, but for many other countries in our global world, it is not possible to have some kind of control at borders. Health control has not either really proven very helpful when we look back at Ebola in West Africa or SARS or so on. I mean, when the evaluation was done afterwards, among those, it did not really prove that it made much of a difference. The only thing that I think at some stage proved reasonably efficient was to have exit control, like they had in West Africa for a while, and that probably made a difference.
Oh, thank you.
Yeah, testing became available very early on, as soon as we got the sequence from China and from WHO. Our lab, who is kind of a central lab for Sweden, developed the test and spread them to all the regional labs. So testing, the problem was not really that, the problem was the volumes. That was later on needed. So, but the test was in place very early on.
And did Sweden have mandatory testing for any particular categories of worker or otherwise?
No mandatory testing. It was really up to each workplace to decide if there was any necessity to who was supposed to be tested and why and so on. And in the Swedish system, you cannot really do things like that mandatory. What the employer then has to do is to tell the person who does not follow the advice from the employer to give them other work. We had the same discussion within the area of vaccines, for example, and so on, that this is the way to handle it, but mandatory is not possible to do.
And in terms of advice being given by the PHA regarding prioritization of testing, if there were limits on the numbers you had, what was that advice? I
mean, for quite some time we did not have the capacity to do community-wide testing because the volumes were not really in place until, I think we're talking May or something like that, when we finally got everything together. And the priority was really to test for medical reasons. That is to sort of steer the treatment of the patient. So this was the first priority. And then the testing of hospital and elderly home staff. Yeah, I mean, that was discussed quite a lot. And I think we still don't really know to what extent. And I think, once again, there is a difference between if you try for an elimination strategy when you want to catch everything and when you want to work with a strategy that just tries to diminish. And it was quite clear to us that the majority of the transmission took place with symptoms, no question about that. So the part that happened asymptomatically was likely fairly small. and not really relevant in the Swedish strategy. But many, I mean, many different researchers have tried to calculate what amount it would be. What we did, which I think is quite interesting, we did this prevalence test, which a few thousand Swedes being tested every other month, different groups the whole time. And we did not find even one among those that tested positive that did not have symptoms. So that's made me sort of really wonder or be quite clear about, yes, it does exist for sure, but it's not that common. And I still remember the very first description of asymptomatic testing of a Chinese woman who managed to infect people at some German meeting, and afterwards it became clear that the people writing the article had not talked to the Chinese woman. She was actually with the symptoms and had taken paracetamol to alleviate those, and there was no question about that. So, yeah, asymptomatic spread does exist, I think, but it's not really very common, and the way we judged it, that in the Swedish context, it was, except for really special groups, it was not really relevant to change anything like around that. It was fairly successful in the beginning with the first imported cases, because then the volumes were small and we could do it in time, because this is what it all comes down to. When volumes becomes high, and we looked into it afterwards because our government asked us to review what was the usefulness of testing and tracing, and we quickly found out that the volumes were so big that you didn't really reach the contacts until it was too late, especially in the later stages when the incubation period was so short. So when I talked to a few, because what happened is that most of the regions established contact tracing centers where they got a lot of people coming in, retired nurses and stuff like that. But I think what they sort of felt as their main function was really to inform people, give people information, both the cases and the contacts, so that they should be more understand what were the recommendations, what could I do, what couldn't I do, and stuff like that. So it was useful in that manner, but the classical contact tracing that we do for STIs, sexual transmitted, does not work when you have these enormous volumes and the big turnover that you have in this kind of situation. And we have had, because we did a review of contact tracing and testing together with our Nordic neighbors, and Denmark was sort of the outlier here. They used testing. They tested, I think each Dane was tested like 8 or 10 times or something like that. So they did enormous. And they, I mean, their main argument for doing this huge amount of testing is to be able to get people to understand that I'm actually infected and infectious. So it did not entail any other obligations or forcings or anything like that. It was mainly to get people to understand that now I need to be careful. They felt it was to a certain extent misused, because young people tended to test themselves and then go to a party. And we all know that testing is only valid for the exact second you do the test. I mean, you might be positive 2 hours later. So it is a kind of, I think we agree by now, it's a kind of a risky way of using it. And I definitely think we need to think more about testing and contact tracing for future pandemics, because this was the first time ever that we could do testing at this kind of level. In previous pandemics, the strategy has been testing and tracing very, very much in the beginning. Once you have a community transmission, there's no need for it, no usefulness. You test the people to give them the right medical treatment, but for nothing else. Now we did a lot of testing, enormous amounts of testing, all through the pandemic, and I think we need to carefully look at that. And of course, it's one situation in New Zealand when you sort of have been able to get rid of the virus and want to stay that way, but a completely different situation when you have an established community spread. And what is the usefulness of testing in that situation? I think we need to carefully look into that, and I don't think it has really been done yet, but hopefully. And then, of course, once again, every pandemic is different, so next time it might be less useful or more useful. We don't know. But it costed the world enormous amounts of money. We gave the first vaccination on the 26th of December 2020.
Wow.
This was a common EU start of the vaccination program because, as you probably know, the vaccines were procured by EU, and the Commission felt strongly that they wanted to make a manifestation on that. So we received only a few thousand doses, but the first vaccine was given on that date. But then the main program only started a couple of weeks later. The Public Health Agency had been asked by the government to develop a priority vaccination plan already, I think, in August or September or something like that. So we went through that, very much focusing, as I said before, on risk, medical risk. And we also took it past our ethical board. There is the Swedish ethical board for medicals. So they also looked at it and approved of it. Basically, it's said to start with the elderly care homes and then go on to elderly people with some kind of home care and other groups also with home care. So they were definitely highest on the list. And then quite soon after that, also other medical risk groups with chronic conditions that considered, and then basically age structure. As I said, we had a big discussion around medical health personnel. We were not very keen on doing that because we didn't really see a high risk in that group in Sweden, which I think is interesting because, as you said, many other countries reported. I think that to a certain extent shows the effectiveness of hospital hygiene in the Swedish setting, which is really high, I would say, compared to many other countries. So, and also that most patients that came into healthcare were not all that infectious anymore because they came in quite late in the disease. But whatever. So, but in the end, we managed to get the regions to say, okay, these are the really essential people, small group, not everybody that works in the hospitals. You will get some vaccines to cover them in parallel to doing this basically age-based work.
Thank you. And in terms of encouraging people to be vaccinated, what steps were taken in Sweden to encourage uptake, if any?
At least in the beginning, we didn't really need to encourage people. That was not the problem this time, which is interesting. It was a big push, and not maybe also because the vaccines came fairly slowly. So there was waiting lines and so on. So people really didn't need to get pushed. They pushed themselves. So, but later on, it was more about that, and then to a certain extent, of course, that you needed to be vaccinated to be able to travel, push people. We should not forget that. I'm not sure how big that was, but it was definitely there to be able to get this kind of certificate that made it possible for you to travel was important. We also really try to reach our hard-to-reach communities in different ways, and the regions and communities worked a lot with that, sort of driving out to big sports events and trying to get into these kind of communities because we could clearly see in our data, yes, they got vaccinated, but they were vaccinated later on. They waited longer than many others. So if there was any push or try to create incentives, it was mainly towards those groups. No, I mean, I completely agree. It was extremely important to have a good system in place, and I think we had. It was very much based on our experience from the swine flu and the pandemics and the narcolepsy. So after that, we really built a very strong system for this with very quick and strong registers both for vaccinations and also big possibilities to report any kind of side effects, both for an obligation for the health services to do it, but also possibility for individuals to report in if they felt side effects. So we had a strong system to catch up signals, and then when we saw a signal, I mean, we have the good registers in Sweden and in the Nordics, so we could actually sit down with our Nordic neighbors and pool those different registers that we had and look at any kind of signal we had. And that's, for example, when we found that Astra had a slight risk of blood clot events, which we didn't think was acceptable, so we stopped using that vaccine and so on. And we also communicated very clearly on this. The Medical Product Agency joined our press conferences at regular intervals and told everybody about how many reports do we have, what do they show, and all of these kinds of things. These vaccines had a fair amount of side effects, light ones, which I mean, I think it's even more impressive that we managed to reach such high levels of compliance, because fever episodes and pain and so on afterwards were very common compared to many other vaccines. So this was, but we followed it very closely, and I think there was a high level of trust in that we did it so carefully.
And you mentioned there AstraZeneca. What vaccines were most used in Sweden?
No, the mRNA. In the beginning, we had more of a mixture, but eventually we went over more and more to the mRNA vaccines. This was, I mean, as you know, the procurement was done on EU basis, so we had signed contracts for a number of different vaccines.
You've mentioned there about being vaccinated protected others. To what extent was that sort of philosophy applicable in Sweden? Were people volunteering to be vaccinated on that basis as well?
I think classically and also when we did the pandemic plans, there was really the hope that the vaccine would work also in stopping transmission. Unfortunately, this vaccine did not do that very well. I mean, there was an aspect to it, but was not very strong compared to what we are used to from measles vaccines and so on. So we never really communicated that as a reason to get vaccinated, because since that protection level was too low, so to speak. So it did not really play in very much. The main role of the vaccine became, and I think that was apparent already from the studies in Israel to begin with, that they could see that a fair amount of people even get vaccinated, tested positive afterwards, not with much symptoms, but still tested positive. So the main reason, I mean, the main objection of the vaccine to start with was really to protect our health services as much as possible, because they were definitely very good at stopping people from getting severely ill and needed medical or intensive care. We did have a vaccine pass. This was an EU-level vaccine pass that was developed in I think all EU countries. It was something that was agreed on, which was mainly used for travel, because a number of countries demanded that you had this vaccine paper when you entered. From the national level, we never recommended it to be used for any kind of events and so on, but still some organizers of events, when they started up late in the pandemic, still on their own accord asked for that to happen. And that was, of course, up to them. There is no sort of legal possibility to, legally they could do that. So that did happen, not very extensively, but it did happen now and then. So it was, as I said, mainly used as a travel tool. I would say that we have a long tradition of voluntary vaccinations in Sweden, and I think to go against that would have really created a lot of discussions and a lot of and a lot of problems in the long run for us. So we were very negative to that. And as I said before, employers needed to do their own risk analysis if the personnel in certain situations needed to be vaccinated. If they didn't want to, they had to put them in another workplace. And this is how we could deal with that. And some employers, especially in health services and so on, where the personnel took care of very fragile people, and they did ask their employees to get vaccinated. If they didn't want to be vaccinated, they had to perform other duties. So it was never really a big issue. And I think compared to many other European countries that I talked to afterwards, this was never really a dividing factor and did not really cause any controversy. People were quite happy about the way it happened, and no discussion afterwards or queries about, we have what most countries have in social media, the vaccine. Anti-vaxxers, so to speak, but for some reason they never really take off in Sweden. We still have a childhood vaccination program that reaches 98% of all kids and so on, and this has not been influenced by this at all. Yeah, as we said before, there was a problem because there was basically no stockpiles, and the whole world market was running after masks. So it was not easy, and the regions, some of them being fairly small, and their possibilities to get out on a world market and buy things were limited. So in the end, the government went in and asked the National Board of Health to set up a system to procure masks on a national level, and then redistribute them to the regions. So that was the solution that was put in place to make it possible to have them available.
And in terms of the consequences of the lack of PPE in the early days, who was deprioritized or who went without, for example?
I think our main problem in the beginning was that the elderly homes and the caretaker, especially the personnel there, didn't have access to, and didn't really have knowledge either to handle them in a good way. So that was really something that was pointed out very clearly, that how big of a part they were in sort of the big problem we have in the elderly homes, I think is very difficult to judge, but definitely the availability was lacking. And I think in the hospitals, they in different way managed to keep supplies enough for their personnel in the hospital setting, so there was never any real problem. But especially in the beginning, the elderly homes had a real problem in getting enough masks into place. Because we then were into a new wave, and there was a lot of anxiety about that this was going to be maybe even bigger than the previous ones. We had quite a high level of vaccination coverage, but the vaccines did not really stop the transmission. So we really felt sort of more or less compelled to have something more in place. And this was one of the few options that we felt were left. And it was quite restricted, because it really said it's better to take the next train than to step onto one which is crowded with a mask on.
Yeah. And were any specific types of masks recommended in Sweden?
Yeah, for hospital personnel, we're talking about the level after the surgical masks, and that's where the masks were used. So, but this was according to sort of the standards put in place already before. So this was the normal hospital hygiene level to use. So there was no sort of surprise about that.
And did knowledge of or acceptance that COVID was airborne have an impact on mask wearing, or the approach to mask wearing recommendations in Sweden?
Yeah, not really, I would say, because we did not. First of all, we have already quite strong rules about the air flow and so on in any kind of public building. So those regulations were already in place, and to increase those did not really seem feasible or necessary. So that was never really a discussion. And I think our focus on trying to find places where there was a lot of transmission was more important than the discussion if it was airborne, droplet-borne, or however it was borne. I definitely agree that this idea in the beginning that all of these surfaces needed to be cleaned all the time, that was never really very important for anybody. But again, I think this division between droplet-borne and airborne is a shaky one. It's not very easy to divide diseases into the two different groups because most diseases spread both ways. And that's why I think we had a focus on these are places where we have a problem, not so much a discussion if this was airborne or not airborne, because obviously it was both, and it depended very much on the setting, which was most important.
And again, are you able to say how effective in Sweden it was in reducing the spread when it was recommended on public transport?
Sorry?
Are you able to say how effective the recommendation was to wear it on public transport?
Probably not very effective. The local region did a couple of small surveys to see how many people actually use masks, and it was very low percentage, 20-30% or something, who actually use face masks. And on top of that, the spread never became as acute as we thought. So that's the reason also why this was quite a short-lived recommendation, because actually what looked like the start of something new panned out, and we did not really have any big problem after that.
And in terms of national ventilation or air quality standards, were those introduced in Sweden, for example, again in health and social care settings or schools?
They were already there, so we did not really change them in any way. It's not completely easy to change those kind of things because it means heavy investments and rebuildings and stuff like that. So, but in the regulations for buildings for everybody in Sweden, there is already regulations on the number of air turnovers and stuff like that. So we lean back on those. I think in Sweden we have had quite a lot more concern about that historically, because we had quite a lot of problems with mildew and stuff like that in many buildings. So that's why we introduced this kind of regulations to avoid that, because I mean, due to the climate we tend to build quite isolated houses, but that also means that you need to have a good possibility of ventilation in place to live with that. So I think we never really had that kind of concern, and I don't think our data even talks about that that we had a big problem in those kind of places. And I think that comes back that we have another kind of building tradition and ventilation tradition than in many other countries.
And there was some criticism in the Corona report about the rejection of face masks as an infection control measure. What are your views on that?
Well, I'm in opposition to my colleague here. I don't think the science and the data is really there. I mean, Cochrane did a review which showed that it's shaky. I think it's incredibly difficult to measure it in doing it blanket-wise. I think you can definitely have ideas, and I think definitely in crowded spaces and so on, they would definitely make a difference if you use them the proper way. And I think you would use them the proper way in those kind of circumstances. But I think the problem that many European countries had, having these kind of blanket mandatory things, and I mean, if you look at these countries afterwards, it did not really help them. I mean, Spain, Austria and many other countries had huge spread in spite of those mandatory. And I mean, you can do a lot of sort of laboratory research in showing that, of course, it stops the virus if you use them the right way, no question about that. But when you try to go out and do population-wide things, I mean, Denmark tried to do one, and they didn't manage to show that it much of a difference. It was a very good study. They sent out face masks to a limited amount of population, compared them to the rest, and there was no difference in the criticism of that was that it was during a time when the spread was not very high in Denmark, so it was difficult to show anything. Another interesting study, which you probably know about, is the Bangladeshi study, where some villages got face masks and some others. And it showed a small effect, but at the same time they also did a lot of other things. So I think it's often difficult to say that this was due to face mask and this was other things. So it's a tricky. It's also a signal which should not be underestimated. So the physical thing is one thing, and the other thing is the signal, and maybe that will make a difference in certain situations. I'm still doubtful, and I still think we need to find more precise ways of using it, because it's both costly and takes quite a lot of information to get it done in the right way. No, as I said before, it's quite different in Sweden. Some 40 years ago, the long-term care was taken away from hospital services and given to the communities and became a kind of social service instead. But otherwise, there's a lot of similarities. They are run by the communities, but they are most often operationally run by different kind of companies, taking over more and more. But they are all, even those ones, are subject to the same kind of rules that everybody else has. So the difference. The people living there paying a small fee, depending on their income and so on. So it's heavily subsidized by the communities. But you also need, and I think I made that clear, you also need to see that in a legal sense, where they live is their home. Which means that they have a fully equipped one-room apartment, so to speak, in most instances. And it is legally their home, which comes back to our discussion about stopping visitors and so on. So it is even legally a completely different kind of setup than it would be if it was a kind of hospital. So I think that's important to realize. And that when this was set up, of course, there was a realization that they needed some kind of support with medical expertise. But that was left to a high degree open, and said that this would be dealt with by agreement between the communities and the health services. Those agreements has only come in place in like 30-40% of the cases and so on. So in some instances, in some relations, there is a very good collaboration. The hospital hygiene people are really very present and helping them. But in some instances, there is sort of really no real good connection anymore. And that so many of them are run by private actors makes that even more difficult. So it's more a kind of a supported home solution than anything else. And the other thing is that the priority in Sweden has really been to make it possible for people to live at home as much as possible. So this has been a very, very strong trend. So instead of moving people with disabilities or elderly people into different kind of institutions, there is a massive kind of support for staying at home. So you can have visitors 5, 6, 7 times a day at home with different kind of categories of. But also those are normally run by the communities, unless you have some kind of medical condition. Then of course also the hospital services will be involved, and I would say all hospitals or health system in the regions also have an outreach section, so to speak, with where they provide medical care in your home.
Okay, well that's interesting, because we'll come on to discuss the accessibility to medical care as well. If I could ask you, Dr. Tegnell, what's the average age of residents in elderly care homes in Sweden?
I don't really have the exact figure, but I know it's well above 80. So, and we talked about it before, I think average lifespan when you enter it, we're talking about a few months. Yeah, definitely recognizes a distinct group, and also quite strong advocates for that and for their rights and so on. So this is continuously a big discussion in Sweden. And they do get a lot of support, but the support is coming out of the communities as a kind of part of the social services. Fairly complicated. They are very sort of, unusually for Sweden, very detailed regulations on what they are entitled to and what they are not. And on top of that, a reform was initiated some maybe 10 years ago when they do actually employ their carers themselves. They don't pay for them, but they are their employers. And this has created some problems because it has been misused. These days we have quite a lot of discussions. It's actually organized crime to a certain extent that misuses this kind of system. So it's under heavy review and so on. But I think the basic background to it was a positive one because it really wanted to give the power to the people so that they could get the kind of care and the kind of care they wanted to have. But they get extensive care and just like with the elderly, the goal is really that they should be able to live at home. And once they get to be adults, they should also have their own home and get the support to be able to have that.
Thank you.
Also very early on. I mean, the data from China already was quite clear about it. And as we discussed yesterday, part of the pandemic plan was really to identify and recognize and work with high-level risk groups. And eventually, when it also hit Italy, it became even more clear. And I even remember the Italian ambassador coming to our agency and just inform us about the risk for the elderly people, which had shown so very, very clearly in Italy during the first waves there.
And were both care home residents and staff recognised as being at greater risk of contracting COVID-19 than the general population?
Yes. Maybe not more contracting, but definitely having worse outcomes. We have looked at seroepidemiology, the number of how many of these people actually had contracted the disease at any time, and it was reasonably low level compared to the population at large with higher levels. So I don't think it was the risk of getting infected that was higher. It was very much the risk, the outcome.
And did that apply to both residents and staff, the outcome, potential outcome?
Yes, staff. I mean, we did look at different professions, and we could see that professions that met many other people had a higher level of risk, of course, and these groups had higher level. It is complicated by the fact that a very high proportion of the people working in these kind of facilities have a background in other countries, which meant that they also ended up in that risk group. I mean, we know that risk group had a higher risk of getting infected due to a number of different circumstances. So it was sort of a double risk, very much. One, that they were out and moving about and meeting a lot of people, but the second also that they socially were in a group where we had a higher incidence, especially in the beginning of the pandemic.
In Sweden, was protection of the elderly an explicit priority, and to what extent that was achieved? Now, I ask this against the background, I think you say in your response that Sweden failed to protect the elderly.
No. From early on, it was a high level of priority, and we went out early on with also giving specific advice to the elderly on how to protect themselves in different ways, and also, of course, made clear that elderly care homes were at high risk. But the complication in Sweden was that they were not really run by any of the normal contacts we had, so there were several levels that needed to come through to really reach them. Some of them did a fantastic job and even could sort of show that they had procedures in place and so on that could stop the spread in there, but many of them didn't. And so it's really, the outcome was very bad. And I think during the first wave, we had like 70% of the deaths in these kind of care facilities were only like very small. I said about 10,000 people are living. So it's, the increased risk when you lived in those kind of facilities was very, very high. And to the extent that actually relatives and so on did keep their elderly relations at home. People were too scared to, because everybody realized that it's high risk to put my elderly parent, whatever, into one of those facilities. So a few of these facilities was actually more empty than ever as a result of the risk that existed there.
And I think you mentioned, that people were reluctant to put their family members in. Was it possible to move people into care homes during the pandemic, for example, from hospital or their own homes?
Yes, and it did happen, and we had big discussions on what kind of level of certainty you would need before you moved them in, how many tests you needed to take, and what kind of intervals and so on. So, and these, I think, worked out, and we also took developed guidelines on what you can. If you move somebody from hospital care into a care home after having COVID, how you need to ascertain that you are not taking the disease with you. And our impression was that was not the risk, really. The risk came heavily from the staff. Every time we did any kind of, or anybody did any kind of more contact tracing activities, it was quite clear that the start of the outbreaks in the elderly homes almost always came back to staff.
And was it possible for people to move out of care homes if there were these concerns, for example, to return to families? Yeah,
I mean, as I said, these are their homes, and of course they are free to do whatever they want.
And engaging in community activities, was that permitted as well?
Yeah. So, I mean, they had the same freedom of everything as everybody else.
Can I ask a question, Dr. Tegnell, please? We've heard evidence in this inquiry that, as well as the risk of staff working in care homes bringing in the infection, care homes, of course, depend on supplies being delivered, all sorts of supplies, and that was at least proposed as a possible conduit for bringing infection into care homes. Was that something that was looked at all in Sweden, or did you have any evidence that suggested that was a route of transmission?
Not really, and I think also, I mean, most investigations really pointed back to staff. And I think it also makes kind of sense, because you need a fairly close, I mean, we can discuss airborne or not airborne, but you need a fairly close contact to infect, and then it sort of made sense. It's the staff who has the close contact, nobody else. I mean, the people bringing stuff there could possibly infect staff, maybe. I cannot say anything. I mean, the next level was difficult to ascertain. But these people not only meet staff very closely, they also meet very many different staff very closely. So their exposure was extreme. I mean, because it was not, I mean, normally you would say in these kind of circumstances you should go to a cohort kind of treatment. But most of these, where you have a restricted amount of people meeting with the sick people, and you don't have staff going from somebody sick to somebody healthy. But this didn't really work very well. They didn't have the structures in place to be able to handle that, which meant that a person living there might meet like 7-8 different staff every day. And of course that increases the risk enormously of meeting somebody who is infectious.
Thank you. Dr. Tegnell, if I can ask you then, to what extent were care homes, and you've mentioned they were people's homes, but to what extent were they treated as residents or hospitals in terms of restrictions or IPC measures?
Not exactly the same way, because they sort of run in different systems, so there was a need to sort of adapt. But we very early on established a specific working group working together with hospital hygiene experts and people from elderly care facilities to develop guidelines for them. So guidelines were developed very early on and iterated over and over again. But I mean, the problem was really that even if these guidelines existed, the staff didn't really have the training and so on to fully implement them all the way. And especially in the early days, there was also a severe lack of protective equipment in those facilities, and unfortunately also a severe lack of possibility to test, especially the staff, but also the residents. on top of that, a lot of the staff, surprising amount of the staff, are still employed on an hourly basis, which means that they fall out of the normal system in Sweden of getting compensation when you're sick. So, of course, the incentive for those groups to stay home when they felt ill in the morning, which we really had compensated in other ways so you wouldn't lose money, did not apply to those groups. And I know from a survey in the Stockholm area that about 30 or 40% of the staff in elderly care homes are employed on an hourly basis. And, of course, it means that they have no incentive to stay home, or because they also, with the social economy and so on, they really need to go to work to get enough money to survive. But it also means that they don't have the training, they are not included in the systems and the quality development in the facilities. So there was a number of weak spots in these kind of places on many different levels that made it very, very difficult to improve the quality of care there as quickly as was needed.
And in terms of guidance and recommendations, was that provided? You've already said that was provided, but did they have any input into that guidance, I'm thinking?
Yeah, no, there were representatives from these elder care homes involved in that. And so they definitely had a possibility to see to it that they were adapted to their possibilities.
Thank you. Thank you. And in Sweden, Dr. Tegnell, was there a required isolation period immediately following any admissions to these care homes?
As I can remember it, we had a required isolation, and I think that was to a high degree also dependent on it. Most of these places didn't really have the capacity to do that, especially the staffing that implied, because it does not only imply that you need to have a person in one room, it also needs that you have dedicated staff to this one person, and most of the care facilities couldn't handle it.
And what about testing before admission?
Yes, that was definitely required, but it was also very much done on a local level in discussion between the regional hospital and the community elderly cares. But the guidelines I talked about earlier, and I think we were up in iteration number 15 or something like that before we were over, so everything changed constantly, and especially on understanding and knowledge about what you could do with the tests and what you couldn't do with the tests. So those things changed as knowledge appeared, but they also included how many tests and what interval there needed to be before you could feel sure of that the person could not any longer be seen as infectious, because that was a big discussion in the hospitals, not only for people moving into elderly homes, but also for people moving inside the hospital. So we had quite a lot of technical discussions on how well can you be sure about that somebody is not infectious anymore, especially for the people who had been sick for a long time with immune systems that didn't really work really very well and so on. So because it was quite tricky, especially in the beginning. Some people had negative tests for a while and then suddenly positive again. And so this really caused quite a lot of concern.
And I think in your report, Dr. Tegnell, you mentioned regarding patient transfer, you note that patients were transferred between different regions. Were those care home residents, hospital patients, or both?
It was done not a lot, but it did happen, and it was mainly ICU to optimize the use of our ICU capacity, and especially in the early days when the spread of the infection was enormously different between different regions, which meant that some regions really had a lot of capacity standing more or less empty, while other regions were overwhelmed. So a few people were moved around, not very many. I have the exact figure somewhere, but it was something. I mean, ICU physicians don't like to move patients because it's definitely not a risk-free, and it takes a lot of resources to do. So it was done in a few cases, yes.
Thank you. If we could move on then to discuss infection prevention and control measures. Apart from visiting restrictions, what IPC measures were taken to encourage the protection of residents, and which ones of those were mandatory and how were they implemented? And perhaps we can start with Dr. Tegnell.
Yeah, I mean, without going into details, we developed protocols both for hospitals and for elderly homes, who gave details about what kind of masks and how they should be used and all those kind of things. And those protocols once again were updated when new knowledge came up. But I would say that in hospitals this was not a big problem because most of these protocols were already in place for people with possible airborne transmission or respiratory diseases. And we do have in Sweden, compared to many other countries, we have a very strong infectious disease clinical group. I mean, we have infectious disease clinics, we have comparatively many infectious disease clinicians, since it's a speciality of itself, and our hospital hygiene has been, for a long time, also been very, very strong.
And we discussed a little bit about bubbles yesterday. To what extent were they used in care homes in Sweden, and if they were used, was that used for outside visitors as well?
I mean, the concept of bubbles were also in Sweden discussed, and I think many people understood that this is a good way for me to diminish the amount of contacts I have and sort of keep it within the family and not meet between families more than absolutely necessary. In care homes, I would compare bubbles to what we call cohort care. Yep. And this was definitely on the agenda and something we really recommended very strongly. But once again, it was quite difficult for most care homes to deliver it in a proper manner, and it was not due to the facilities but due to staffing, because a cohort means that you need to have the dedicated staff for that group of, and really made it very, very difficult for these places to keep the amount of staffing at the level that they needed to have it. So I would say that yes, some places managed to have these kind of bubbles in place, but many didn't.
If I could maybe ask you a little bit about PPE before we come on to ask Sir Ashley, was PPE mandated for care home staff and for community carers or residents?
We don't really use mandates in that way in Sweden. You are supposed to follow the protocols and give care according to evidence and good practice, and that's very clear in the law. And it's up to the whoever runs the facility to see to it that happens. So if staff does not want to or doesn't care about this, once again, they will be replaced. But sort of an official mandate, that concept does not exist.
And in terms of PPE, what was recommended then for use amongst care home staff and residents?
We tried to go for the same standard as we did in hospital care, but in practice that was, especially in the beginning, difficult. So whatever was available, which was unfortunate, but the only way to do it.
And we may have touched on this yesterday, but was the care sector treated akin to healthcare in terms of priority for PPE supply?
Unfortunately not, I would say, because it lives in a different system and quite often doesn't even procure these kind of things themselves, but sort of buys it from the region. So they don't really either have the systems in place to actually procure these kind of things in an effective manner, because they didn't have the relations to the industry and so on, and were also very small buyers. And that's part of the reason why eventually the national level went in and told the National Board of Health and Welfare, okay, you need to procure face masks and a few other things on the national level with big quantities, and then the system started to work better. But the system we had in place before the pandemic couldn't really handle this really enormous increase in demand.
And I think you mentioned you mentioned some examples earlier. I think what other measures were used within care home settings, for example, screens, isolation protocols, or limits on possessions were coming in or out when visits were allowed, or were those not required in Sweden?
Yeah, I mean, the protocols were quite detailed. So telling very much about what you're supposed to do if a patient or somebody living there have symptoms, telling about testing and isolations, and as far as possible limited the amount of staff that meets them and so on. The protocols for visitors were also quite detailed, sort of clearly recommending meeting outside if possible. As I said, many care facilities also created specific places outside with these kind of screens so that people could meet and really minimize any kind of contact as much as possible. Also quite detailed advice about personnel to get tested, and eventually when testing became a bit more accessible, also making quite clear that they had a priority when it came to testing, because testing was supplied by the regional level. So in the beginning this was a bit difficult because the regional level really used most of the testing for their own staff and for their own patients. And the possibilities for elderly care staff and so on to be tested was quite limited in the beginning, but that improved quite rapidly.
Thank you. And Dr. Tegnell, if I could ask you, was that the case in Sweden as well?
In Sweden we have a special authority for supervision and inspection that does inspection in all different kind of care facilities. Which is, and they also approve, if you want to start like an elderly home and so on, they would approve you as a provider of that. And then you need to sign a contract with the community, of course. But so that's, yeah, we use a little bit different words, but I think the process is similar. And they don't really do regular inspections. They do inspections when there is a signal that something is wrong. And they also might do inspections when they see a more generic problem. So quite limited. So I would say that the Swedish system depends very heavily on your internal quality control systems. And there are very strict regulations about that you need to have one in place, and that you also need to have the possibility to send a signal to the inspection authority if you see that something has gone wrong. And that's a legal requirement of all these kind of facilities. This did not, I mean, we had a number of whistleblowers during the pandemic when staff in these kind of facilities went out and said that this is definitely not right. Our facility is not living up to the standards, and they are not informing the inspection authority of that happens. So this was quite a big media thing that not everybody lived up to this. But the system is built like that very much that you have a very high level of responsibility to have a control system in place. And if you get signals that your care is not up to the standards that's given by the Public Health Authority or the National Board of Health and Welfare and so on, if that's not up to those, you need to report it to the inspection authority, and you also need to do your own evaluation and start improvement measures at once. Yeah, during the pandemic, this was maybe not really all the way there, but the inspections continued and the system kept on working, so there was no limitations to that due to the pandemic, rather the opposite. But we have a continuous discussion if the inspections are really done often enough, and if this internal quality system really works the way I think we're reasonably happy with how it works within the big hospitals, because they really take quality very, very seriously. But for some of these private providers in the elderly care sectors, sometimes not quite all the way.
Thank you. If we can move on then to visiting and family involvement, and perhaps start with you, Dr. Tegnell. Could you explain broadly the nature and extent of any restrictions on visiting care homes? And I think you've probably answered this in your answer about the fact that this is people's homes, but if you could just explain broadly the nature and extent, if there were any restrictions on visiting care homes, both for elderly residents and for people of all ages, including those with profound intellectual multiple disabilities, and whether that was by phase in Sweden or...
Yes, early on when we saw what was happening in the elderly homes, there was a blanket ban on visitors to the elderly homes in the first spring. And that included all facilities, even included hospitals, so no, any kind of facility like that. Later on, as we moved on and we had discussions both with our ethical committee but also with our legal advice and so on, it was quite clear to us that this was not really neither ethical nor legal nor probably effective. Because we got more and more information from the contact tracing that took place in these kind of places. And as I said, exclusively I would say that it was the staff that took it in, and this is not finger pointing at the staff and saying that there's something wrong, but they had that kind of relations with the people there that made transmission possible. While visitors already knew what it was all about, they kept a lot of distance, they often took the elderly people outside and met outside and so on. And many of the elderly homes also installed different kind of screens and stuff like that. So there was definitely a lot of measures in place that stopped the transmission from visitors, which meant that we took that away, and we actually went the other way. And together with the government, there was a decision taken that you can only stop visitors in your elderly home if you have very, very good reasons to do that. So the elderly homes who wanted to do that, which number of them wanted, because having visitors took a lot of staff, needed to spend a lot of time on that, and it was quite complicated during this period, and there was a worry and all of that. So a number of elderly homes really wanted to have a ban for visitors, but then they needed to go to the local communicable disease officer and get their approval, and then it will end up with us at the Public Health Agency to sort of decide, do they have sufficient grounds to actually stop visitors? And after that, none of the elderly homes had a blanket ban on visitors. So during the rest of the pandemic, people were allowed to visit. And I still think that this visitor ban really caused a lot of unnecessary grief, because if there is something people really regret, is the possibility, lacking the possibility to say goodbye to their elderly relatives and so on. I think that was really sad.
Thank you.
Not restricted in that sense, but prioritized, I would say. So some elective procedures, I think we talked about it yesterday, were postponed especially because intensive care places were not really present, and you need to have that in the background for quite a lot of those kind of procedures. This is normally what occupies most of our intensive care units. Not everybody knows that, but this is what it's all about. So priorities like that, of course, made that some people had to wait longer for those kind of procedures. But otherwise, no restrictions, I would say. It was really, I mean, the signals were really to deliver care as much as possible. Remotely, very much so. And this is something that in Sweden, with the big distances in parts of the country, already to a certain extent has taken place. And we have quite a lot of also private providers of remote care. So there's quite a lot of experience in that field. So I think that primary care felt less of a pressure than normally, but this was more due to the people were slightly scared of going to the health facilities because they really felt that this is the place where I might get infected. So primary care had less visitors than normally. But I mean, everybody who needed care definitely got care, and there was never any question about that. And I think also when we try to follow up afterwards, I talked, for example, among people in charge of our quite extensive programs for cancer prevention and so on, and they say that when it comes to breast cancer and so on, the number of people coming for checkups and so on remain basically the same as before. So even if they had a lot of procedures in place to avoid meeting many people. So, and I think also afterwards, when we look at the outcome of many health conditions, that in general it seems like the system kept on delivering healthcare more or less to the same level as before. The heart doctors in Sweden say that they see a slight tendency to more people coming in with heart failures. And they think that people to a certain extent avoided going to care when they had chest pain, especially during the first spring, and that maybe some cardiac problems that could have been treated early on were missed, not because there were restrictions, but people did not really like to go to hospital. So slight tendency in that, but otherwise we don't have any signals that the treatment for NCDs in general did not keep the quality that it has had. And I think also what we've seen in Sweden, that the average lifespan and so on has very quickly gone back to the same curve that we had before, also says that no, we don't really have a problem with that. Personally, I think that a considerable amount of the excess deaths that we see in many countries is not due to COVID only, but also due to that many of the NCDs did not get the kind of treatment that they normally would have done. No, the same. There's very strict protocols in place, very strict obligations to the doctor who decides on this to have a close dialogue both with the patient when possible and with the relatives. So that's definitely something that's very strong and also discussed quite often, and the inspection also goes in and look at this. I think in hospitals it works normally very well. In these elderly care homes, it becomes a bit more complicated in many ways because it's many of them don't really have the cognitive abilities to really understand what it's all about. The level of doctors actually being present is much lower than the thing you have in New Zealand. So even if officially there is a primary care physician in charge of the facility, they normally don't come very often and so on. So there it often, I think the impression was that it felt quite shaky, and not really so much about CPR per se, but more about the discussion around should these people be transferred to hospital care and ICU care. I think that's where we had a big discussion. Is it relevant to move somebody into intensive care? And this is, of course, a continuous discussion always, because intensive care is always a limited resource, and you also need to understand that to get some benefits from intensive care, you need to be fairly healthy. So if you're very old and frail, intensive care tends to just extend the suffering. And to have that understanding and to get that understanding, and especially to apply that to people living in elderly care homes where they didn't really have a regular doctor that knew very much about them. I think that's where we had quite a lot of discussion. And, so that's really something we need to think more about and discuss more. It's not CPR, because I think that's easier. But this discussion around should you get the benefit of intensive care or not, or benefit, should you be moved into intensive care or not? I think that was very heavily discussed, and there also came out some kind of protocols from one of the regional jurisdictions saying that people from elderly care homes should not be moved into ICUs at all, which of course is completely wrong. You can never take that decision on that kind of level. You need to do it by individual. So this was also ended up in media, and they had to withdraw it, of course, at once. But yeah, it caused tension, and especially since these places are not very well manned by medical professionals. We gave quite detailed, and once again we had a working group working on that, seeing what kind of IPC measures are possible in schools and how they could be used. And the schools worked very much with trying to avoid big gatherings, so the morning gatherings and so on that sometimes took place before were not in place anymore. They also tried to spread out the school day, so not all the children were not there at the same time. We don't usually do that in Sweden, but now we did it. And sort of altogether diminish the contacts as much as possible within the school setting, not having lunch at the same time and all. Yeah, all of these kind of things you can do while keeping the schools and the curriculum running.
And Were schools closed for under 15s in the event of any outbreaks or spikes?
Yeah, I mean, it happened that school closed for a few days, maybe a week sometimes. Then, in a combination with also that so many people were actually sick, especially among the staff, that you couldn't really run the school in a normal manner anymore, and also to break the transmission within the school. So that did happen, and in close collaboration with a local communicable disease officer in the region. Those kind of, but the decisions were taken by the dean, or the, what do you call it in English, the head of the school. Yeah.
And for over 16s, they were required to do distance learning for a few months at 2 stages, which I understand was until September 2020 and from December 2020, unless they had training that could be done or that could only be done in person, for example, vocational training. How was distance learning managed during those, for the rest who were required to do distance learning?
It was done by the schools, I think in a very similar manner to what's happened in New Zealand. And the teachers basically set up the training in a similar manner they would have done with the pupils in the classrooms. So it was done on Teams or any Zoom or any of these kind of sites. And fortunately in Sweden, people are to a great extent on even fiber, so they have very fast internet in almost all places, even out in the remote areas of Sweden. And computers have, in different programs in Sweden, been subsidized by the states. So access to computers and so on is very, very high. And when that did not work, the schools also supplied the students with them. So that transition, as far as we can understand afterwards, went fairly smoothly. The teachers were not happy because it's not optimal, but I think what we can gather from the school results afterwards, in those age groups, school results did not deteriorate noticeably. And that cutoff was made partly because it is a normal cutoff in the Swedish school system. We have the first 9 years as a basic schooling, and then you go into what we call a high school, which is then voluntary, while the first 9 years is compulsory. Homeschooling is not allowed. So it was a natural cut, but it was also a cut where we did start to see that at least some children start to get sick, but also that the school authorities told us, okay, about that age, we believe that most students will be able to benefit from a distance learning in a similar manner that they would to an in-person learning.
And that probably ties into the next question. What was the rationale for how schools and colleges were dealt with in Sweden? In other words, for keeping younger children in school and allowing older children to online learning or distance learning?
I mean, we have had this discussion in Sweden before, during our pandemic planning. We had a very intense discussion around what do we do about schools during a pandemic, not least because many countries, especially in Asia, tend to close schools during flu outbreaks and so on. And I think they see some kind of effects of that. And I think that generally children are seen as kind of an engine in flu outbreaks quite often. So it's a different kind of concept. But still, we didn't really see that the benefits were all that great even then. And we had concerns then we went through what the possible effects were in different ways. I mean, one of the effects would be that we would lose a significant amount of people working, especially in hospitals. I mean, you need to remember that in Sweden, both parents usually work and also tend to work in similar places. So if one of the parents work in hospital care, the other one also works in hospital care. So we could calculate, because of all our registers, we could calculate that the hospital services...
Interrupt you there. I've been told that I need to ask you to slow down slightly. It's being transcribed, so they're not managing to catch everything, all this valuable information. So if I could ask you just to slow down a little bit, please.
I'll try to. It's probably a sign that I've talked about this too many times. We could calculate that hospitals might lose up to 20% of their staff, which would have significant effects on during a pandemic. And when we also went back to this in the start of the pandemic and had very intense discussions with school authorities and so on. We really saw that school closures would have immense effects, especially among the children already at disadvantage. And that group is a significant group in Sweden and not really something to take lightly. And we could also see from the figures from China and other countries, and also from Sweden very early on, that children very rarely got ill. I mean, the children that needed hospital treatment were extremely few. And when we did prevalence studies and so on, they didn't even get infected very much. And this was in the early days. I think Omicron was very different. And I think that's one of the reasons why you see the high level of among teachers in New Zealand, because that was during Omicron. We had a completely different profile, infected children a lot more, and was a lot more infectious. But in the early days, children were definitely not the engine in the pandemic, rather the opposite. So any kind of argument for closing the schools and having an effect on the spread of the disease, we didn't really see them as very, very strong. But the arguments for keeping them open and providing the children with knowledge, social interaction, and especially the disadvantaged children, were very, very strong. And we had intense discussions with school authorities and with teachers and so on. But in the end, I think, especially when it sort of all started up, we had a huge agreement among teachers and others that this was really something we did that was very useful. And we also did comparative studies with our Nordic countries that did close schools for extensive amount of times. And we tried to see if this affected the spread in the community in any manner in those countries. And no, we cannot really see that. And we still talking early, during the first year or so of the pandemic. So I think there's sort of consensus, at least in the Nordic setting, that keeping schools open was probably a good choice.
And just in terms of remote learning for over 15s, in terms of educational outcomes, how effective was that, or how successful was that?
No, it's from the, I mean, we do have national tests and so on, and we can't really see that there was any deterioration in that. When we get up to university level, many universities in Sweden already have extensive program for distance learning due to our long distances sometimes and so on. So this was not a very difficult transition for them, because they had most of those things in place, and they had all different kind of learning platforms and so on that was already used extensively. So for those groups, it was more a social thing that many people move away from their home and live in student quarters and so on, and got quite isolated. And that, I think, is the remaining problem. Just on the sideline, we do see the same trend in Sweden as you do in many countries among younger people, that mental, at least the way reported mental health is increased. There's many discussions if this is due to that young children these days are more open about it and can talk about it, and that I'm quite sure that part of it is there. But there is also other things going on. And we have been following those curves, and the curve during and after the pandemic remains the same. It's a slight increase every year. It did not, during the pandemic, did not change anything. I don't have the details here, but I know that there has been studies in other European countries with extensive long-term school closures, and that has really increased the level of mental ill health in those countries. So I think there is quite a strong connection. But I think, as my colleague said, that it is very much depending on how long and what kind of things you put in place to alleviate. So there are many aspects to it. I think there's quite extensive reports from poorer countries that closing schools was really very, very harmful, with girls not coming back to schools, forced into marriage, and teenage pregnancy on the increase and so on. So, as many other things, it's very much about context. Absolutely. If you have a good context, you can probably close schools for at least limited amount of times without too many ill effects. But if you don't have those compensatory mechanisms in place, school closures will lead to very bad results in many places. No, we could, since we have all of these registers, we could follow quite closely how different occupational groups were affected. And it was quite clear that the occupational groups that could not work from home did get infected more among those teachers. But teachers were at the same level as bus drivers or any other kind of group that needed to be out in society to work, because it was an essential service that could not be performed in any other way. And there were, we had a lot of dialogue, so there was also quite a lot of understanding around this, and also that we could show that very rarely any of these people really got severely ill, even if it did happen, because they were most of them young and fairly healthy, so it was not all that dangerous. But still, there was intense discussion because the occupational safety laws in Sweden are very stringent. So there were some concern among bus drivers and also other groups at some time that their protection was not really as high as it should be, even if we could show that it was very uncommon for them to get severely ill. And I think this balance between occupational health laws and the needs, the things you need to do to keep the society running is a discussion that we have ongoing, because it's not completely easy, especially when the occupational laws are as strict as they are in Sweden, who really gives the employer a very high level of responsibility to keep the employees from any kind of increased harm. So that we had quite intense discussion between the different agencies, the Occupational Health Agency and us. What can we possibly do during a pandemic? Don't we need to sort of, to a certain extent, accept that we cannot really fulfill all our obligations during a pandemic? And in their system, then no, there is no way out of that. You always need to supply the highest level of protection.
And just the final question, how did rates of post-viral sequelae or long COVID for school staff compare to other groups? And again, I think this is something possibly you've touched on yesterday.
I haven't seen anybody doing that. All the studies I've seen, there is a number of risk factors for long COVID, but I haven't seen that occupation is one of them in any of the studies I've seen so far. But it's, I'm not sure if anybody run those yet. It seems to. Yeah, it's clearly connected to when you were infected, because the earlier on in the pandemic, the higher the risk. It also depends very much if you were vaccinated before or not, or if it was the first time or the second time. So there's those kind of things that play in. But so it probably has more to do with the incidence and prevalence in a specific occupational group than anything else, I would say. So it's clearly connected to that. So I wouldn't expect teachers to have long COVID any more than any other occupational group that also were out in the society. Maybe I should start with saying that the Public Health Agency, in its mandate and traditionally, did not really communicate with the public. It was not sort of something we were asked and supposed to do, but rather that role was given to the communities and to the regions, who has this sort of operational responsibility. So normally we would develop knowledge and even messages, and they were given primarily to the regions, and the regions would use them in different ways and so on. So, but what happened this time was that didn't really work, because it would have taken too much time, and it would be too much of a time lag and so on. So quite early on, in spite of that, it was not normally what we did. We started this daily press briefings, televised and so on, which became incredibly popular. I think we had 3-4 million viewers on something that was incredibly boring. So that was quite interesting. And it's also important to understand that we were actually asked to do this by the political level. We had run a few, and we were more or less saying, okay, now we've done that, let's somebody else do it. But then our Minister of Health came to us and gave us officially to do this kind of daily press briefing together with the other major agencies, which was the National Board of Health and Welfare, who took care of the hospitals, and the contingency agency, MSB, who took care of the civil preparedness. So then we stood there together for, as I said, 198 times. So it was a major effort in many ways, but also, I think, extremely useful, and I think very insightful of our politicians to understand how important this was. And we really divided up the communications in two blocks. Technical communication was done by the three of us. The political communication, when the politicians had been involved or needed to be involved or needed to reinforce something, they did their own press briefings together with the directors of the different agencies. So it was a clear division, not standing beside each other, but a clear division. And also at the political level, they had a fair number, not as many, but I think 40, 50 or some press briefings doing this. So it was not an uncommon that we had both press briefings, first one at our place at 2 o'clock and then one at 4 o'clock in the government offices. And as I said, it proved incredibly valuable in many ways. And I think it also comes back to what in Sweden has become very, very important, and that's transparency and openness, which meant that all the data was always available to everybody. Had interesting side effects that many use this data to do completely new kind of analysis that we never even thought were possible to do. So it's giving out data like that has some interesting effects. But it was very much about that, and it also meant that we had to employ a team of, I think, 5 or 10 different lawyers just looking at everything that the media and everybody asked for us to give out, because, of course, everything was public, that could be public, but individual data and so on were not allowed to be public, so we need to scan everything. So this also cost an enormous amount of work for the agency to be as transparent as we were supposed to be. And we worked very hard on that, but never really managed to keep up, because it's supposed to be speedy. When you have hundreds of demands every day on extensive, I mean, sometimes they ask for all the emails that came out of my account, and I had, during the first year, I had 40,000 emails coming into my account. So and then all of those had to be scanned, so that no personal information happened to. So there were side effects to this, but on the whole, it was very successful, very appreciated in many ways. The one thing we struggled with was, you also talked briefly about that, was to reach all different kind of communities. They're more complicated in Sweden because it's a lot more heterogeneous. We have, I mean, there are schools in Sweden where they have like 20, 30 different languages. Wow. So our migrant group, which is 20-25% of the population, comes from a wide range of different countries, different cultural background, different languages. So this was an enormous challenge. We did not really, we worked very much with it. We worked very much with it together with the regions and the communities, but still. And also because integration of those groups in Sweden has not really become as successful as it should have been. So there's many backgrounds to that, of course. But it was really a challenge. And on top of that, many of these groups relied heavily on information in social media from their home countries, which was not always the same kind of information that we gave in Sweden. So there was many reasons why those groups did not, even if we translated them, I don't know how many different languages we did all of these kind of normal things. This remains a problem, how to reach these groups. And we have afterwards worked quite a lot with trying to find peers in those groups that can work as kind of translators into those groups, which seems to be working reasonably well. So that's what's the big challenge. to reach the sort of majority of the population through media and so on, that worked, and people were quite pleased about it too, and I mean, really.
And specifically, children and young people and people with disabilities. You've touched on hard to reach groups. What about children and young people?
Yeah, I mean, we also try to design specific communications with them, and I and other people also appeared, and we have a special news programs for children where one of my really interesting experiences to come and talk in those kinds of newscasts that they did. So we also try to reach them and also through social media in different ways to adapt. And there is already a law in place in Sweden saying that everything we put on our web needs to be adapted so that people who have different kind of disabilities can also access them. So and that applied, and we adapted. So for people with difficulty in reading, you could click on it and everything would be read up. So all of those kind of things are in place all the time, and so we work quite a lot with that for many years in trying to do that, because translating tables and curves into a speaking voice takes some
challenging.
Yeah, but those things were in place. So I would say that to the extent that it is possible to reach those groups, we did as much as we could. No, I mean, this is a global phenomenon, so I think this exists all over the place. And I think the difference is maybe mainly in what kind of uptake it sort of has. And I think that comes back to trust that we discussed. If you have a high level of trust and so on, then you can get past that. And I think our basic strategy was very similar. And we learned that from the vaccine area, where we had worked extensively with this kind of misinformation before, and talked to different kind of experts that gave a very clear advice about do not go into communication with the people who said that this is dangerous and so on, but try to make available good information in your trusted channels. And we kept on working like that. I would say we did cannot really remember an instance where we actually went out and said something about faulty information out there, but generally we just supplied what we considered was the best information available at any given time, and that was really the strong strategy that we had. Of course, we had people that kept on scanning the social media and so on to try to understand what's going on, so that we could see that if some kind of strange information was appearing, that we could sort of come out with the correct information in the same kind of area. So it was not that we ignored it, but more that we tried to sort of compensate for it, and also use social media very much for trying to understand what are the major questions for people at large during this time. What do they want to know? What do they need to know? So that we could supply that kind of information very clearly to them. I have a similar experience. I mean, in spite of there were certain groups of the Swedish society that we didn't manage to reach as well. On the very whole, communication was essential in getting the amount of response that we actually did get. And that response was enormous. I mean, we did surveys and people said that they changed their life. 80-90% of them consistently go through it. We could follow mobile phone operators, seeing that people stopped moving around. There were side effects like in the first fall we didn't have any flu cases at all, which showing that social distancing was really penetrating. We could also follow people work from home. 50% of the Swedish workforce work from home. So people really changed. And in spite of international media saying that people in Sweden kept on living like normal, it was completely wrong. And of course, if you do use a wide angle camera and go and stand in a certain place, it could look like there were a lot of people in the streets in Sweden, but no. I mean, the hotels were empty, the streets were empty, like they were everywhere else. So the impact was enormous.
Oh, sorry.
Just to add to that in the field of vaccine, we usually talk about the efficiency of vaccine and the effectiveness of vaccine. The efficiency is what we do in RCTs to sort of see that it's safe and that it sort of, at least in this very small population that we test, it is also give protection. The effectiveness is what happens out in the population. And the two of them are not very seldom similar. Sometimes you get more and sometimes you get less. So this is a well-known phenomenon, and as I would say, it's also not the right tool, but it's not even an ethical tool to use at that stage. And I think we have similar studies from many places. We could also show that the protective level for elderly people not to end up in hospitals or in ICUs were like 90–95%. So it was a very good vaccine. And I know that WHO has come out and said we have saved somewhere between 2 and 3 million lives in Europe alone due to the vaccinations. So they did an enormous difference to our hospital services and to the mortality.
Thank you. Well, I can perhaps ask you part A of the question then as well. In your opinion, was the program that was used in Sweden effective? And if you consider it was effective, in what way or ways was it effective, and amongst which groups?
It was very effective in saving many of our elderly.
Sorry, I've just had another request. If I could ask you to slow down a little bit, please.
No, it was very effective in saving many lives, for sure. It was very effective in helping our hospital services to have a reasonable workload during the spring of 2021, because when the new variants came and everything, and the waning immunity and many things coincided during that time, we saw actually a very big spread, the biggest spread we had ever seen from COVID-19 during that spring. And if we didn't have so many of the most vulnerable people protected by the vaccine by then, I think that would have been a great risk in Sweden for our hospital system to be overwhelmed. No, as I said, I think we all agree, and I think the Swedish Corona Commission and several others pointed to the necessity of having good legal instruments and good practical instruments in place so that we can run big follow-up registry-based studies very quickly during a pandemic to get a better understanding of what's actually happening and not least the effect of interventions that we are starting up.
Thank you very much.
Can I just add to that in the aftermath of the pandemic, we had a lot of discussions and reviews in Europe, and one of the suggestions from that is that we need to be much better in following up the effects of what we are doing, and I think that's what we need to do. RCTs will never really help us, and they will probably be unethical and unpractical in many ways. But on the other hand, we need to have a better system in place so that we quickly can collect data and follow up the effects of both interventions and the disease. And there is a number of projects and initiatives in the European setting to make this possible, to access even more data than we had this time, and to do it jointly in a manner that we can very quickly sort of follow the development. And I think that's really what we need to do to be able to do the right thing and to change when needed to change.
Thank you very much, Dr. Tegnell. We next have a series of questions for Dr. Tegnell, and this is from the Scottish Vaccine Injury Group. The first question is, in your testimony on the 24th of September, you twice referred to immunity levels in the community and once mentioned how that data was fed into your modelling to help predict hospital capacity requirements. Can you tell us how you measured immunity levels?
It was done by what we would call a prevalence study. What we did in practice is that we, by random, chose some 3,000–4,000 people in the Swedish population, spread all over and being representative as much possible. And then we asked those people to test themselves and send the testing to us centrally so we could run them. And that way we got an idea about how many people at any given moment who actually were carrying the virus, and that gave us the prevalence at that given time.
Thank you. the second question is, if you were able to measure immunity or antibody levels, was any consideration that vaccines may not be necessary for individuals who already had natural immunity, particularly as the vaccines that we had a witness the other day, Dr. Ashley Croft indicated earlier this week, were new gene therapies, so it was not yet certain if the benefits outweighed the risks for every age group.
We had a considerable discussion around that. Was it necessary to vaccinate people with already somehow proven disease? Mm-hmm. And we discussed it back and forth in different ways, and our conclusion was yes. One is that the immunity was, even after natural infection, is not very long-lived, quite short, starting to wane after 3 or 4 months. And then giving an extra boost by also vaccinating people would prolong that period and protect them much longer. And also that there were studies showing that having natural disease and then getting also the vaccine increased the protection even higher up, because not even natural disease gives a complete protection. So we ended up that our conclusion was yes. And beside that, it was also the complexity of sort of saying who has enough antibodies and how shall we test them, and it's quite expensive to test for antibodies, and we are now in the middle of a mass vaccination campaign. It was not really feasible to run that specific way of doing things, even if the question was asked by a few people now and then. I'm not aware of any comparison of healthcare workers in different countries, unfortunately. As I said, we did repeated register-based studies on the risk for different kind of professions. And we did not find that the health profession had a very high level of risk of getting infected. And within the high level, within the health profession, we found that the persons at the highest risk of being infected were actually people working in psychiatric diseases, showing that people who don't know that they are meeting people in more social circumstances than as a patient and a doctor are probably more at risk. And the people that actually knew that they were meeting people who had COVID were able to protect themselves really well. So, and if there is a difference between health personnel in different countries, I'm not aware of that. Sorry.
And do you think, well, you've probably just answered it, do you think that you were doing anything else differently from other nations to protect your health care staff?
No, I think in that area, I think there was quite a lot of international consensus about what was needed to be done to protect your health personnel. And as evidence, or at least understanding of the disease and how it was spread and so on, I think we got better and better at it. And I think in the end we can say that we were able to protect our health staff reasonably well. Once again, when we go back to our contact tracing and so on, then when we found outbreaks among health personnel, we could usually trace it back to the cafeteria or the what we in Sweden call fikapaus.
This is a question for Dr. Tegnell, and it's from the Scottish Women's Rights Organisation, I think, double check. And it is whether and to what extent Sweden experienced an increase in instances of domestic violence during the pandemic.
No, we did not. And there are signals from several other countries with long-term lockdowns and so on that there were an increase in domestic violence, but in Sweden it remained at a very constant level, and I think even slightly diminished, I must say. But I need to check the data to be completely sure. But at least there was no increase.
Thank you.